Yes, everyone, the webinar is just begin.
Assalamualaikum. Tes.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, esteemed guests, distinguished speakers, and participants from all around the world. Welcome to the international webinar, One Heart, One Move, Breaking Barriers for a Coordinated Implementation. I am Deamala, your Master of Ceremony for today's event. It is my pleasure to welcome you all to this important event. Well, to officially commence our programs, we have a series of welcome addresses from esteemed guests who have joined us today. These addresses will provide us with valuable insights into the importance of one heart, one move. Without further ado, let us welcome our first speaker. The first speaker is Professor Indi Dharmayanti, Head of a Research Organization of Health, National Research and Innovation Agency, or BRIN. To Professor Indi, the screen is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning,
Waalaikumsalam.
afternoon, and evening to all participants. Distinguished participants, respected speakers, researchers, and practitioners in public, animal, and environmental health. Leaders of international organization, Indonesian Epidemiological Association, French Embassy in Indonesia and Timor-Leste, University of Montpellier, Mahidol University, World Federation of Public Health Agencies, and all participants on this online webinar symposium, whom I'm honored to welcome. Let's start by giving thanks to God Almighty for providing us with the chance to gather in a virtual conference room for this crucial international webinar symposium. Our subject for today, One Health, One Move, Breaking Barriers for Coordinated Implementation, highlights the pressing need for the Asian region to address global health issues in a comprehensive and integrated manner. One Health is an approach that integrates human, animal, and environmental health to collaborate together. It emphasizes the interdependence of our health and the need of the cross-sectoral collaboration to prevent zoonotic infection, combat antibiotic resistance, and strengthen ecological resilience in the face of the climate change. Today, One Move program attempts to break down barriers between disciplines and promote a better coordinated implementation at the local, national, and international levels. In recent decades, the globe has encountered health challenges that put our resilience and collaboration to the test, such as the COVID-19 pandemic. This epidemic has taught us a vital lesson about the value of interdisciplinary collaboration and a quick and efficient cross-sector intervention. Today, we will talk about how One Health can help with this effort and how we as a global society can particularly put this idea into policy and practice. Ladies and gentlemen, I believe that by taking part in the International Webinar Symposium, we are in a proper place and time. Let us work together to speed the exchange of ideas and adoption of the best practices. I hope that this webinar will provide an opportunity to share information, expertise, and innovation. I am certain that through meaningful discussion, we can develop One Health initiative that are not only successful, but also realistic for implementation across several nations, empowering local communities to drive change. On behalf of the Research Organization for Health BRIN, I would like to acknowledge everyone who helped organize this event, the speakers who will share their points of view, and each participant who is eager to learn and participate. May this event go well and benefit all of us in our effort to make the environment better and more sustainable place. Enjoy the two-day webinar and let the session inspire and bring a concrete action. Thank you. Wassalamualaikum warahmatullahi wabarakatuh. Wassalamualaikum warahmatullahi wabarakatuh.
Yeah, thank you so much, Professor Indi, for the welcome address. For the next welcome address, we will hear from Dr. Haryadi Wibisono, the Director of PAEI. To Dr. Haryadi Wibisono, the screen is yours.
Thank you, Ibu Dea. Good morning, good evening to all of distinguished speakers and participants. It is my great pleasure to welcome you on behalf of Indonesian Epidemiological Association to the online international webinar with the theme of One Health, One Move, Breaking Barriers for a Coordinated Implementation. This seminar will be conducted for 2 days, organized by the French Embassy of Indonesia and Timor-Leste, the National Agency for Research and Innovation, Indonesia Epidemiological Association, University of Montpellier, Mahidol University, and the World Federation of Public Health Association. This two-day seminar will be conducted through online and participated by several organizations, including research institutions, universities, government with various disciplines, from educators, researchers, and policymakers, and etc. We are very grateful to the organizing committee with their hard working to make these seminars go smoothly. As you know, there are a range of perspectives on how the One Health approach be implemented in the field. The spirit of identify the opportunities for innovation, cooperation, and collaboration among all relevant sectors and disciplines is very important. Particularly interesting will be to learn the priorities and development from several local, regional, and international institutions. Thank you. Have a good and productive discussion. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much to Dr. Haryadi Wibisono. Next, we will move to the welcome addresses and from Professor Artit Ungkanat, the Dean of Faculty of Medicine, Ramatibodi Hospital, Mahidol University. The screen is yours.
Distinguished guests, honored speakers, and valued participants from across the ASEAN region and beyond. It is my honor to welcome you to the online international webinar on One Health, One Move, breaking barriers for a coordinated implementation. This event embodies our shared commitment to a healthier, more resilient world. Through this symposium, we aim to connect minds and experiences, fostering collaboration that will drive impactful changes in One Health across our regions. The One Health approach, recognizing that the interconnectedness of human, animal, and environmental health is crucial in today's complex world. Our gathering today includes esteemed partners like the French Embassy in Indonesia and Timor-Leste, the National Agency for Research and Innovation, the Indonesian Epidemiological Association, Mahidol University, and the University of Montpellier, reflecting our united goal of coordinated action across borders. This symposium will also feature a distinguished lineup of speakers, including Associate Professor Kamthorn Malatham from our own Faculty of Medicine Ramathipati Hospital, Mahidol University. Associate Professor Malatham will offer valuable insights on managing antimicrobial resistance through One Health approach. His expertise will illuminate how One Health principles can be applied to address AMR, a critical global health challenge, particularly within the complex dynamics of hospital environments. We are honored to have Associate Professor Malatham represent our faculty and share his knowledge on this urgent topic. As we embark on this two-day journey, we will explore three crucial themes that lie at the heart of the One Health approach. Number one, One Health program in Asia. This session will examine programs in Asia and beyond, showcasing how they adapt to local challenges and cultural diversity, providing valuable insights for global best practices. Number two, interoperability and social integration. We will discuss the importance of both technical and social aspects in implementing One Health, focusing on building resilient health systems that integrate data and practices across disciplines. True interoperability requires engaging communities and stakeholders. Number three, coordinated international implementation. This session will address the need for collaborative action among nations and organizations, exploring ways to unify policies and practices in order to effectively tackle global health challenges. It emphasizes that collaboration is essential for achieving One Health goals. These discussions are designed to inspire actionable outcomes, including a collaborative article for influential publications and practical guidelines for implementing One Health on the ground. In partnership with the One Health Working Group of the World Federation of Public Health Associations. Together, let us begin this journey toward a future where One Health is not only a guiding principle, but a reality. Thank you for your dedication and welcome to the One Health, One Move Symposium.
Yeah, thank you so much for Professor Artit. Well, we will next to our welcome address and will be delivered by Dr. Thierry Goubir for Attaché for Scientific Cooperation French Embassy in Indonesia and Timor-Leste. The screen is yours. Okay. We will, next to the another welcome address, and it will be delivered by Dr. Lohong Gilbert from University of Montpellier. The screen is yours.
Thank you. So I'm a doctor in ecoepidemiology at University of Montpellier, and it's an honor to me to be a part of this important symposium dedicated to advancing in the coordinated implementation of the One Health concept. Today, I would like to highlight the key role of scientific research and knowledge in effectively supporting One Health policies. As we come together to discuss actionable strategy, it's crucial to recognize that the strong scientific foundations enable us to address the complex interconnection between human, animals, and environmental health. Through this symposium, we'll explore how evidence-based research can inform and strengthen policy alignment and on-the-ground action. By integrating science into the decision, we enhance the resilience and adaptability of One Health initiative. So I look forward to our collaborative insight and collaboration toward practical solution to make a tangible impact. So thank you and good webinar for all.
Yeah, thank you so much to Dr. Ulohong Gawat. Next, we will hear the welcome address from Dr. Masdalina Pane from BRIN Cibinong. To Dr. Masdalina Pane, the screen is yours.
Good morning and good afternoon, everyone. On behalf of the organizing committee, I'm honored to welcome you all to this international scientific webinar on One Health. I would like to take a moment to acknowledge the head of the Research Organization of Health, the National Research and Innovation Agency, Republic of Indonesia, Professor Indi Darmayanti, who is playing a critical role in organizing my team in this webinar. As a key entity for research in Indonesia, BRIN highly upholds ethics and professionalism in all aspects of scientific life. The BRIN's commitment to advancing ethical standards in research and fostering a collaborative environment has been instrumental in bringing these webinars to life. We are deeply leadership and vision, which ensure that our work is not only scientifically precise, but also socially responsible and inclusive. We are truly grateful for the opportunity to bring together such a distinguished group of researchers, practitioners, and professionals who will share a common commitment to advancing the interconnected fields of human, animal, and environmental health in Asian countries. We respect ASEAN values, which is crucial when engaging in a webinar or any collaborative effort within the Asian region. The collaborative spirit and shared knowledge that divide this field are more important now than ever as we continue to address the complex health challenge of our time. I also would like to express our deep gratitude to our distinguished speakers who will be sharing invaluable expertise in these 2 days. Your contribution will be truly appreciated, and we are excited to hear your insight on the critical issues facing One Health today. I would also like to extend a heartfelt thank you to all of the participants for your enthusiasm. Your presence and involvement are crucial in making this webinar a success. And we are eager to hear your thoughts, questions, and reflection throughout the event. A special thank you goes to our team and all the individuals behind the scene who have worked tirelessly to bring this event to life. Your dedication and effort are deeply appreciated. This webinar would not have been possible without your hard work and commitment. Finally, I would like to thank all the institutions, organizations, and partners who have supported us in making this event a reality. Your collaboration is to fostering the global conversation necessary for advancing One Health. We look forward to a fruitful and engaging discussion in these 2 days. Thank you once again, and I hope you all enjoy the webinar.
Yeah, thank you so much to Dr. Mas Dalina Pane for the welcome address, and for the last welcome address will be delivered by Professor Xiaoneng Zhu from NIPDWLPHA, Shanghai, China.
Thank you. Thank you. Good morning, ladies and gentlemen, distinguished guests. And I'm very happy to participate in this webinar, which one word, one health, and one movement, which help us to understanding more on the concept of the One Health and promoted us to make more actions in the future. As all of you know, human civilization development has been moved very fast, but the civilization is one flight away from infectious disease based on the lessons we learned from COVID-19. So the question is how can people and nature coexist harmoniously? This is really important to solve the complicated health problems issues by using the One Health. Well, the One Health concept has been developed very well for a long time, but on the December 1st, 2021, 4 international organizations, including the FAO, WAHA, WHO, UNEP, has set up the One Health high-level expert panel. They made the definition of One Health. One Health is an integrated, unifying approach that aims to sustainably balance and optimize the health of people, animal, and ecosystem. Although the One Health approach has been well recognized, its application in shaping policies and practice has still been inadequate. So we need to remember that One Health should be cooperation in the different disciplinary experts. And also we need a communication among the different departments or different sectors. Also, we need coordinating some actions among the different regions. All those would like to improve our capacity on One Health immediately to convey together to those outbreaks or pandemic of the infectious disease. It's really important of this seminar or webinar, which will really bring all the stakeholders or sectors from a different area working together. So on behalf of the One Health Working Group of the World Federation of Public Health Association, welcome all the speakers to give your thoughts, give your experiences to this platform. So we hope this platform of the webinar can really make a contribution to the One Health action at the national level or subnational level in the future. So I hope this webinar will be succeed. So last but not least, I would like to thank all the preparing work from our Indonesia teams or French team to make this webinar possible. Thank you once again. Thank you.
Yeah, thank you so much, Professor Xiaoneng Zhu. Okay, for the last but not the least, we have Dr. Thierry Goubir will be deliver his welcome addresses, and he's from Attaché for Scientific Corporation France Embassy in Indonesia and Timor-Leste. The screen is yours.
Thank you. Hello, everyone. I hope you can hear me well. Okay. Dear distinguished speakers, dear participants, I am proud to be able to welcome you to this webinar on One Health, One Move, Breaking Barriers with a Coordinated Implementation co-organized by the Indonesian Agency for Research and Innovation, BRIN, the Indonesian Epidemiological Association, PIOE, the University of Montpellier, the University of Mahidol, the World Federation of Public Health Association, and the Embassy of France for Indonesia, Timor-Leste, and ASEAN. I am impressed and honored by the variety of speakers gathered for this event, representing many institutions, countries, and various areas of the One Health continuum, with a focus on practice in ASEAN. I thank the organizing committee for their investment in motivation in preparing this event. One Health has been instrumental in understanding and envisioning the link between humanity, its environment, and its health in an encompassing global view. It's also for a layman like I, faced with public health programs in the region, a hope in being able to tackle effectively environment-linked vector-borne disease and emerging illnesses. For France, One Health is a global effort and advocacy on the multilateral stage, with initiatives such as PRESOD and linked with the credit partite to translate One Health into an effective, actionable process for better health and future pandemic prevention and preparedness. However, due to its encompassing transverse nature, One Health poses unusual challenges. The number of different institutions, ministries, and entities that have to coordinate to implement One Health is staggering, while we still need to maintain a strong focus on science and research, since so many is yet unknown in the field. Change is needed in many fields to be able to open up and integrate with others to be able to realize the integrative vision of One Health. Therefore, I hope through the different renowned speakers in this webinar, we'll be able to see the barriers we need to break and a contribution to our path toward the One Health journey. And of course, slightly late compared to that, happy One Health Day to everyone. Thank you.
Well, thank you so much. It's our last welcome address. Well, everyone, before we move to our agenda, we have a group photo session. So for everyone who have joined this webinar, please to open your camera. Yes. Wait a moment. We're still waiting. Everyone who haven't opened the camera. Okay. Yes. Please give the best smile ever. Okay. 3, 2, 1. Okay. Once more. Wait. Yeah. 3, 2, 1. Okay. Thank you so much, everyone. You can give online applause for us. Yes, before we move to keynote addresses session, we have break around 15 minutes. 15 minutes, I mean, it's not 50, yes. It's only 15 minutes. After that, we will next to our agenda. Thank you. Yes, everyone, we will start our next session in 8:50. Yeah, good morning, everyone. Well, to following the welcome addresses, we will now move on to the keynote addresses. Our keynote speakers are experts in their respective fields and will be sharing their knowledge and experiences on one per one move, of course. Yes, and for this session will be moderated by our moderator, of course. And for this session will be moderated by Dr. Lehong Gevot from University of Montpellier. So, Dr. Lehong Gevot, the screen is yours.
Thank you. So good morning for Asian people, afternoon for European and African, and evening for North and South American. And welcome for the introduction session of this webinar. We will begin with three keynotes that will allow us to explore different frameworks for the effective implementation of One Health concept. So just a quick note about organization. We will hold a dedicated question and answer session for all three keynotes just after they are concluded. So let's start. It's my great honor to introduce our first distinguished speaker, Professor Zhu from Shanghai in China. Professor Zhu is currently Chief Scientist for Parasitic Disease Control at the Chinese Center for Disease Control and Prevention. In addition to this work at the CCDC, Professor Zhu is the owner of the chair of the One Health Working Group of the World Federation of Public Health Associations. Today, Professor Zhu will be sharing his insight on a global perspective of One Health and its governance. So, Professor Zhu, the screen is yours.
Thank you. Thank you for your introduction. It's my pleasure to share with your experiences on a global perspective on One Health and its governance. So first of all, I would like to thank all the organizers to invite me to give the report on this topic. And it's a really big topic, so I will try to figure out how to use this concept by three different topics. So first, I would like to introduce One Health concept. Second, then I would like to introduce what is the global One Health governance achievements up to now. Then I introduce a little bit about the One Health activity in our Shanghai Jiao Tong University, China. So what is the One Health concept? As I mentioned in the opening speech, the human civilization development very fast from the primitive civilization, agriculture civilization, industrial civilization. Now we are in the stage for the environmental civilization. With those developments, people getting more and more closer from the tribe, village, urbanization. Now we are working on the globalization. Then these make people more communications and have chance to talk each other more closely. But the human civilization is one flight away from infectious disease based on the lessons we learned from COVID-19 or even the previous pandemic such as SARS. So the question is, with the increasing population density, how can people and nature coexist harmonized, right? And this question, we need to answer by using different way or dimensions. So let's look at those pandemics or big outbreaks. For example, the HANRS, Nipah, SARS, MERS, Ebola, and COVID-19. All these virus infectious disease or emerging infectious disease outbreak actually came from the wild animals first, like bats. Then this virus actually spill over through the wild animal into the domestic animal. Different domestic animal species actually serving as intermediate animal host responsible for human infection. So through those domestic animal, because they are close contact to the people and very easily to be exposed to the people. So human get infection through this channel. So this actually, we also can understand more community, international community take attention on the One Health issue. For example, the G20, G7, all mentioned these issues. And for example, the G20 in the 2020, actually a big pages actually talk about the anti-COVID-19 activities. At the same time, also mentioned that we need to continue tackling antimicrobial resistance and zoonotic disease based on the One Health approach. All this actually encourage us, or particularly as professionals working on the One Health, we need to work harder in the future. Let's look at the evaluation of the One Health concept. And in the ancient time, particularly in China, 1,000 years ago, the Chinese traditional medical doctor has mentioned that animal veterinary doctors and the human medical doctors actually working in the similar principles. And this concept actually continue to be maintained until the 1964, and Professor Calvin Schwartz from USA and put forward the concept of one medicine, which integrated between veterinary medicine and human medicine. So this actually, after the SARS, and some community also proposed the ecosystem health, which actually I started working on this from that date. And ecosystem health, in short name, they call it eco health. But not far away from that one, the One World, One Health concept was proposed. And up to now, the One Health becomes a very hot topic. You can look at the right side of the curve, and One Health concept or publications increased significantly since 2010. Compared with the global health, quite similar patterns occurred. And One World, One Health actually originally proposed in the year 2003 by the Wildlife Conservation Association. And then in the Madrid conference, they proposed the One World, One Health as in the meeting. And until the 2019, the principle on the One Health also proposed to further confirm that the updated One Health approach effectively reconnects the health of human, non-human animals and ecosystem in an economic and social political context. So the global environmental changes and the COVID-19 pandemics starkly remind the wide world of these foundation interconnections. So the BRIN principles are an urgent call to action for the cooperation and multiple cooperation particularly. So until the year 2021, the FAO, OIE, WHO, and the UNEP worked together and signed the agreement, and also established one of consultancy committee. It's called the One Health High-Level Expert Panel. Made the definition that One Health is an integrated, unifying approach that aims to sustainably balance and optimize the health of people, animals, and the ecosystem. So, which focus on the 4 C's. So first C is cooperation in the interdisciplinary professionals. And also we need the second C, communication among the multi-sectors. And also need a coordination in the different regions, multi-regions, to improve the society capacity on the One Health. So One Health capacity building is really important in the future. We work together with the community level. It's very important. So let's look at what's the benefit of the One Health concept. As you know, all the pathogens, or for example, virus and bacteria and parasites are living in the environment. The first exposed to the animals first. So animal had the sick, so veterinary doctor will take care of this. But later on, those pathogens continuously exposed to the humans. And the human got the infections or outbreaks, those are taken care by the human doctor. If we are separated the cooperation between veterinary science and the medical science, then the one outbreak will increasing the cost for the one outbreak, like a red curve. So we need to cooperate closely between veterinary and human scientists or doctors. Then we can reduce the cost of one outbreak, like this curve of the red curve. But it's not enough for the One Health governance. So One Health governance should be work together with the multi-sectors and cooperate each other more closely. So such as like this, we need to start from the beginning and make the more integrated surveillance. Then those costs can be reduced as much as possible. It is really reflected. We can work together. And those 6 benefits actually came from the World Bank analysis. So One Health can support poverty elevation program and also improve the economic growth in the developing country. Second, it can reduce the pandemic risk globally. As third one is improve the public health globally. The fourth benefit is help build the effective animal and human health system without weak links. So this is really important. And also, fifth benefit is help build efficient animal and human health systems. The efficient because of the shared capacities and information, reduction of the duplication, economics of scope, and economics of scales. So finally, the benefit is we can really get the cost benefit significantly. The net expected annual benefit between 4 billion in the non-pandemic threats and the 35 billion in certain situation like one severe pandemic per 100 years. So with the high probability of pandemics, benefits are even great. So it's really can encourage, this number really can encourage all the government to think about the One Health governance, which is really important. So we need understanding One Health approach by the systematic thinking. System thinking is really help us to control those pandemic significantly. So we need to use analytical approach to identify the real problem in the real world first. Then bring those real problems into the scientific question or hypothesis to investigate or test it both in the laboratory or in the field. So all those outcomes of the research actually need to transfer into the piloting studies or intervention studies. But those outcomes of the piloting or intervention studies need to be assessed by the cost effectiveness evaluation. So actually, then we can promote and scaling up into the real world. So all this One Health approach, we need to think about at least the 3 steps. First, need to take the research. Second one is take the implementation. And the third one is evaluation. Then it really can be implemented or scaling up in a national level or subnational level for this approach. So this is a complexity health problems is become more complicated. So we need a more system thinking way to solve those complexities of the health problem. So health problem, actually the more complexity and the dynamics. So dealing with this complexity and cope with the increasing dynamics and has become the main challenge in the project or program manager. So the system thinking really can help us working on the One Health governance issue. So it is a holistic thinking and is important. So I would like to take one of example as a Schistosoma japonica, which not only happened in China, also in the Philippines and in Indonesia, in the Southeast Asia. So the parasites actually infect the human, but also affected to the 40 species of mammals, which means animals, particularly the water buffalo. And those animals or human feces goes to the environment. The eggs of the parasites can hatch into the myriacidia, and one myriacid goes to the snail. It's called uncommon snail. Thousands Cercaria can be hatched, and those Cercaria are sitting in the top of the water and very easy to be infected to the human animal when those actually contact the water. So you can see all those human animal environment factors involving this cycle of the parasites. But if we need to control or even the interrupt of the transmission cycle, we need using not only the scientific knowledge or techniques, but also we need involved by the One Health governance issue. I will show you that. So in China, more than 12 provinces, more than 100 million people at risk. At least we find about 12 million cases in all the time. And within the last 7 decades, and the infection rate goes down and down. And now by the end of last year, 0 infected cases or 0 transmission sites was found. And also, so we are leading to the elimination or eradication of the disease now. And actually, those are actually a lot of intervention is working by the One Health approach. For example, the integrated strategy to control the transmission of schistosomiasis in China was actually published in the New Lancet, New England Journal of Medicine. And we found some pilot study results really good compared with the control group in the marshland of the Jiangxi province. And you can see we not only replace the water buffalo by the tractor and also set up the fence to separate the snail habitats and also give the washing project or carry out this. And this not only can reduce the infection rate for schistosomiasis in different pilot province, also can reduce the snail infection rate of those in those pilot area. At the same time, the soil transmitted helminths like Ascarius tricolores also decreased with the time. And so this actually effectively reduced because it's local people happy to using it, but also the disease disappear totally. So it's really can consolidate our achievements for these results. And these results also can be supported by our modeling. So for example, this line, blue line, actually only the chemotherapy we take in the human, but those actually curve cannot be goes to the zero, except when we dealing with the snail and the water buffalo together. Then the infection rate can go zero in the marshland area. And this is in the mountainous area. So our approach is not only by the health sectors. If the sales sector, this red line cannot be goes to the zero infection rate, but we need to add the ecological interventions. Ecological intervention can increase our results, and the blue line can goes to the down and until zero. So now this county, Yuan, in the Yunnan province and in the mountainous area, and already eradicated this disease 5 years ago. So actually, particularly during last 10 years, and China made a very, very great efforts to eliminate schistosomiasis by the multi-sectoral cooperation. For example, the Minister of Health, Minister of Agriculture, and Hubei governor of the Hubei provincial governor, they joined together, signed the agreement to eradicate this disease. At the same time, those approach also translated into the China national regulation for schistosomiasis control. And because of this, and the multi-sectoral cooperation become more effectively or efficiently. So you can see all the provinces where the endemic for schistosomiasis and working in different ways, and particularly manager of the animal reservoir wash. And now because we are already goes to the elimination stage, and so take a more integrated One Health surveillance. So integrate surveillance and response system becomes stronger and stronger by using the One Health approach. And so by the end of last year, all the endemic area of 12 provinces has reached to the interruption criteria of the interruption of the transmission. So we need waiting another 5 years. If we still maintain this eliminating status, then we can declare China is free of schistosomiasis. So this we are working on. By this years, we need to make more intensive surveillance and response. So, and global One Health governance is really important at the global level because those 4 VIPs from WHO, from FAO, from OIE, from UNEP, they are joined together and signed agreement once again recently, and to make a great important. So they also made the new definition, as I mentioned, by the OLEP. And so particularly this, they put forward that this important actually formulate this One Health joint plan of action. and this at global level, working together for the health of human, animal, plants, and environment. And at the same time, they also put forward a guideline to implementing the One Health Joint Plan of action at a national level. So this national level document and really can provide the guideline for all different national or subnational work on the One Health. And this actually really important. At the global level, we need to focus on the 6 track and those track, but at the national level, we need to take the 5 steps. For example, situation analysis. Second one is strengthening the One Health governance and coordination. Third one is planning for the implementation. Fourth one is implementation of national One Health action plans. Fifth one is review, sharing, and incorporation of the lessons learned. So all those 5 steps, if the country make the national One Health working plan, action plans, and this need to take care of those 5 steps. And of course, this 6 tracks actually combined with 3 pathway. This is based on the series of thinking and make the intermediate, middle term outcomes and long-term outcomes to really improve our impact for One Health actions at the national level. So the scientific committee, or we call the OLEP, term 1 was finished by between the 2021 and 2023. They produced many guidelines or books to help with understanding One Health concept on governance issue. And the second term has been started from early of this year, and now I'm serving also the term 2nd. So recently, these 4 VIPs from different international organizations actually meet again, and they would like to promote the more cooperations among the different sectors. So and they made the consensus on the following 4 points. First, we need a relentless focus on the implementing the One Health joint plan of action in countries. Second, implementing the plan of action in countries will require investment. And the third one, we must ensure science and evidence guide all the One Health interventions. Fourth one is we must maintain political engagement and advocacy for One Health. So as a working group of One Health working group of the World Federation of Public Health Association, we would like to also involve more on the guideline development for One Health intervention, which Professor Roger Frutas will be leading these activities. And now the qualified OLEP will be set up in 5 new actually thematic group, including the governance, policy, and advocacy, One Health joint plan of action implementation, quality and stakeholder engagement, integration of environment in One Health, and economics of One Health. All those wording, particularly the economics of One Health, it is the first time to be used. So, and when we talk about the interdisciplinary or transdisciplinary work for One Health, so you can see if the disciplinary separated is like 3 cycles here, and multidisciplinary, they just using this work together. But for the transdisciplinary, you should be some interface between these 3 cycles. But more important, we are now emphasize we need to work together in the same room as the transdisciplinary. So the transdisciplinary really can improve our efficiency, not only financially, but also technically. So This is very important because transdisciplinary can really strengthen our adapt to the knowledge-based modern socio-economic development. Also can strengthen our adaptation to the requirements of international competition. Third one is can adapt to the future challenges in integrated education and cross-disciplinary studies. So these three characters, these three characters really help us understanding why we need improve our One Health governance capacity. It's very important. So actually, the transdisciplinary cooperation is really important. Recently, we analyzed the top 500 scientists working on the One Health, and we found that and those actually you can see their cooperation not only across the country, but even across the continent. And more and more scientists were working on the One Health with more publication in the recent years. And also they cross different field of science. You can see there are more and more multidisciplinary involving into the One Health, showing by this figure. They are not only working on the clinical or health issue, also the life science, physics science, social science, engineering, and technology. And this last three, physical science, social science, and engineering and technology is still weak. We as One Health scientists, we need to involve more of those scientists work together. So all this we analysis really help us with understanding how to do more work on the transdisciplinary cooperation in the future. So the transdisciplinary, we can see they can help us for the innovation, integration, synergistic symbiosis, and superiorities. So if you are working on the one discipline, maybe only need one professional institute and a research team and academic societies. But when you're working on the transdisciplinary, you need improve your interdisciplinary platform, multidisciplinary research team, interdisciplinary research results, and also the multi-academic societies work together. And then now I would like to introduce what we have been done after the COVID-19 in Shanghai Jiao Tong University. So before the COVID-19, in the June 2019, we set up the School of Global Health, co-sponsored by Shanghai Jiao Tong University School of Medicine and the Chinese Center for Tropical Disease Research. But after COVID-19, we set up the One Health Center, co-sponsored by Shanghai Jiao Tong University and the University of Edinburgh. So which means we are not only the education institute, but also the research institute focused on the One Health issues. So our One Health Center is to improve health and the well-being of human and promote to build a community of common health for all mankind. And we set up our organized as 4 different departments, including the Department of Infectious Disease and Tropical Disease, Department for Animal Health and Food Security, and Department for Environmental Health and Eco Safety, and also the Department of One Health Governance, and all the other platform or administrative to support this work. And we work on the different universities and different departments and different subjects and working together. And so focus on the 4 functions: education, innovation, research, and think tank, and knowledge hub. And of course, supported by big data center of One Health. So all the students and actually they not only learning knowledge in the classroom, but also practice at the community level or even the international practice. And we normally arranged in the summer course, they have visited other developing country to practice in the field with the One Health concept. And we also provided the continued education to different partners, government staff to focus on the One Health. So in the One Health Day, and students went to the community for the health education and tell them about the One Health stories. And at the same time, we also set up the One Health Action Commission. We attract more international scientists, and we discuss about our research priorities for support the joint action plan for the One Health at the global level. So we identify the research priorities based on this 3 cycles. You can see those interface 1, 2, 3, 4 is our research priority, as well as the governance is our another research priorities. So we identify these 5 priorities in our center now. And during last 2 years, we developed the first Global One Health Index, which consists of different indicators, about 107 indicators. And we collected we formulated this platform framework first, which including the external drive index and intrinsic drive index and a core drive index. And the results showing that in the 160 countries around the world, the score of the index, One Health Index, is differently. You can see for the developed country, Europe and North America, they had a high, but a very low occurred in the sub-Saharan Africa countries. But for the 5 different dimensions, which including the AMR as well as the governance, is a very low score showing that. So these 2 areas we need to work very well. So we published the paper in the infectious disease property, and the correspondence was introduced by the Nature. And we also compare with the different patterns in the different year of the One Health scientists. This is the first stage. You can see the cross-continent cooperation, but more recently, we're showing more cooperation occur in those scientists, and particularly in the Asia or Southeast Asia, and including Australia and Oceania, there are more scientists involving compared with the previous years. So this is really important for us to work together in the future more. And we also had some research pilot study in the Chongming Island of suburb of the Shanghai city in the very small scale, but also we working on the global level for the zoonotic disease issue. And for the AMR, yes, we in the Chongming Island, we collect example from a bird, from the domestic animal, from the human, and from the water, from soil. All those we made a surveillance together and understanding what's the transmission pattern of the AMR genes. So not only the regional level, also the global level, we work together. And for the environmental issue, we develop different tools to make the more sensitive monitor of the changes in the environment, water, soil, and air. And so now we focus on the small island in Chongming Island in Shanghai, but we also scaling up into the Hainan Island. This is the one province in the southern China. So we hope this demonstration pilot study can be transferred into the global level in the future. So, and these are really important for our future scaling up. So, and we also engage the global level by international organization and different countries. And also we set up the Chinese consortium for One Health. We work together for the 3 issues. One is the knowledge information exchange. Second one is knowledge promotion. Third one is work together on the scientific research. And we published or launched the new journal called Science in One Health. I'm the founding editor together with Professor Masatena from Switzerland. And at the same time, we're working on the One Health Action Commission, as I mentioned. And now we also set up the One Health Working Group for the World Federation of Public Health Association. And we started working this year, and together with our my friend Professor Roger Frutos. And also in this webinar, many experts from this working group will give the presentations and introduce their experience from a different corner of the world. So thank you once again for your attention. Thank you.
Thank you very much, Professor Zhu, for that insightful presentation and with very nice and sounding examples. So it's now my great pleasure to introduce our next speaker, Dr. Aryadi. So Dr. Aryadi is the director of the Indonesian Epidemiological Association. And today, Dr. Aryadi will present on PIAI, leading the fight against zoonotic disease through One Health. He will share valuable insight into how Indonesia is tackling zoonotic disease and the role of One Health in building a stronger and more resilient health system. Please, Dr. Aryadi, the screen is yours.
Thank you very much. Before I start my talk, I can feel the atmosphere of enthusiasm proved by so many speakers during this today and tomorrow with their perspective from the different angles of their disciplines. So allow me to share my slide for this. And is it shows? You can see my slide?
Yes, yes, thank you.
Wait. Yeah. If we are talking about the One Health, and particularly the zoonotic disease, so this is a very important and crucial topics. And One Health has been developed for many years with a different perspective and different definition. So by 2020 has been developed new definition by the One Health high-level expert panel, an advisory panel for the One Health now, the quadripartite made up of the FAO, WHO, AIDS, and the UNEP, and says that One Health is an integrated, unifying approach that aims to sustainability, balance, and optimize the health of people, animals, and ecosystems. It recognizes the health of humans, domestic and wild animals, plants, and the wider environment, including ecosystem, are closely linked and interdependent. The approach mobilizes multiple sectors, disciplines, and communities at varying levels of society to work together to foster well-being and tackle threats to health and ecosystem, while addressing the collective need for clean water, energy, and air, safe and nutritious food, taking action on climate change, and contributing to sustainable development. This is very ideal definition, but I would like to bring this for the next question, that who will do their role on this implementing the definition, and who will do what, and then how they do their contribution in One Health approach. Because as stated, that is the interdisciplinary between the human health, which is consists of so many zoonotic disease with several disciplines involved, from the clinical side, from the public health side, and of course from the laboratory side, and as well as the research side. And it is very much related with the animal side, which is consists of from the government side, who responsible to handle the problem from the animal side, and which government side will do that, and how they will do to intervene the animal problem, including the wild animal, and then how they can work together to have the same perspective in order to have a one vision of One Health. So I'm talking about the zoonotic disease, especially in Indonesia. At the human side, we have several problems of zoonotic disease in the human. Start from the anthrax, from the leptospirosis, from the brucellosis, and also the dengue, hemorrhagic fever, and rabies. And each of these diseases will affect the population at the grassroots level, with the various of socio-demographic difference, with the geographical variation, and also with the differences of capacity of the local government to tackle this specific problem. At the animal side also, how they can define it is a problems from the animal side, very much related with the mission of the government side on animal side, whether this is from the animal welfare or from the economical perspective. Based on that angle of observation, they develop the policies. And of course, the policy, they have many challenges on develop policies related with the capacity, related with the human resource. And the last one, the environment. If we are talking the environment, it's again very wide aspect, with the problem of environment, with the climate, and how to deal with the climate change, how to deal with the deforestation, how to deal with the flood, and everything. And for that, again, the policies very much related with the available resources, available limited resources. So problem priority setting is one of the consideration. This is one example that for the anthrax, we have problem of anthrax, although there's some declining the number of anthrax from 2023 to 2024. But again, anthrax is from the human side, it is very dangerous when human infected with anthrax. On the other side, anthrax, when they infected the livestock, it's caused some economical loss. And between this, we can see that there is some bargaining how to deal with the economical loss and also the human threat. So better understanding how to avoid the anthrax in the animal side will be give the good impact on the human side. The other one is the rabies. The other one is the sorry. Yeah. The sorry. Yeah, the rabies. Rabies is quite a problem in Indonesia because it's between the human and get the rabies and also the wild dogs or dogs with the infected with rabies. This is again a problem that how can we work together to make sure that all dogs are vaccinated. Dogs belong to the owner. It's more easy, but the wandering dog, it's not that easy because it's difficult. And also the availability of sufficient vaccine for the dogs is also another challenge. On the other hand, in the human side, once people get bite by the dogs infected with the rabies, it's become a deadly case. The third one is the leptospirosis. As you know that with the climate change, with the urban slum area, the trend of leptospirosis is increasing because with the slum condition, with the environment unhealthy, and then with the flood, and the risk of leptospirosis is increasing. So for that, you can see there's some slight increasing from between 2023 and 2024. And then also for that we have to deal with the suspected anthrax, suspected rabies, and leptospirosis. I bring this suspect because for this it shows that how important the lab function, how to collect the specimen and rapidly get the answer, and then based on the lab result, we will make immediate corrective action. Means that the specimen collection and transfer to the lab and also lab examination should be inline in a very quick manner without any disturbance on whether from the reagents here stock out or transportation of the specimen. As you know that condition in Indonesia with the so many islands where they cross the river or cross the sea takes difficulty for the bringing sample to the laboratory. So again, when we talk about the zoonotic diseases in human, animal, and environment, the first question is whether we have the data. Data availability is very crucial. Completeness and timeliness. Completeness and timeliness of human human sick person due to the zoonotic disease, and also zoonotic disease among the animal and environment. Data availability is very complex because it takes the capacity to identify, to recognize the diagnosis, and then how to collect the specimen, and then how to define disease yes or no based on the symptom, and also from the laboratory set. For this, the information system is very critical because the complexity of information system now with the new era of online information system, the challenge is that not all area can be accessed with the internet. So it means information system needs some complex but accessibility and understandable at the operation side, at the entry side. It means we have to have a capacity of human to enter the data into the information system. The second problem is that how information system can be accessed by the reporter and also by the management level at the district, provincial, or at the central level, or even international level. So this combination of data availability and information system are a challenge for to have how One Health approach can be developed. In Indonesia, at the animal side, they have the ISIGNAS, it's the information system for the animal welfare. The challenge is that how can the ISIGNAS connect it well with the human information system? And in some area, the mechanism of the reporting system sometimes need to have a better coordination at the cross-sectional level between the people at the front line from the animal side, make network with the people for the human side at the front line. And this is as well for the environment side. So for this, as I mentioned, very much challenge on how infrastructure in each aspect, infrastructure for the human health, infrastructure of the animal health, and infrastructure of the environment. Is it possible to link between those infrastructure? Many years we try to develop integrated surveillance. The question is now, integrated in which level? Integrated at data collection, or integrated at the data analysis, or integrated at the action side? Because surveillance is action. Surveillance is analysis for rapid action. So when the analysis is still solitary, it's become non-effective compared to if can be integrated with other side. Surveillance for human side integrated with the animal side and environment will get better information. For that, of course, need resources, sufficient resources on human resource, well-trained people at all levels, well-trained people at the grassroots level, well-trained people at the management level, at the medium, at the district level. How can they work together? How can they have the same perception? What is the One Health concept? How they can integrate? But on the other side, each district have their own priority. One side, they have a rabies problem. Another district, they have leptospirosis problem. Another district, other disease. And some other district have the environment problem. So this infrastructure, resources, and priority setting have to put in the strong consideration in order to have a better One Health approach. So I try to make this diagram that every discipline starts from the policymaker, from the educator, from the community side, and cross-disciplinary research put in a well container, and a coordination, interoperability, standardized regulation, and global management and education. This is One Health approaches. So the result of this, the type of the container is how can policy development be developed, and also can be conducted research on risk analysis. Without the mix of the multidiscipline in a one container on cross-coordination, interoperability with the same standard, the same perception on how to standard, how to regulate with the global management using the One Health approach, the risk analysis cannot have a sufficient result. So the challenge that limited resources is in place. Various organization infrastructure. Some infrastructure very strong, like in Indonesia for the health infrastructure, we have the health infrastructure from the central up to the district, up to the village level. We have the mobile health services. But on the other organization with the limited resources, they have different infrastructure. This is also related with the human resource deployment. The third constraint is the geographical constraint. As you know that we have a lot of islands, we have a lot of cross border, we have a lot of river, makes the every activities have some challenges. That's why, and the last one is the priority difference. As I mentioned, in one province or one district, they have their priority A, which is different than in district B, we have the priority other than in district 1. So for this, we have to understand the variety of resources, infrastructure, and priority difference. So in summary, the zoonotic disease for many years have caused several outbreaks, pandemic, and millions of fatalities. The bird flu hit in Indonesia in 2006, 2007, up to 2017, we still have the case. It's caused 16 million deaths of poultry, and also a lot of about 200 casualties in human side. And the big one, the COVID-19 pandemic have caused of death, human death, economic loss, and social impact. One Health has contributed significantly to develop better protection of human, animals, environment through a multidisciplinary approach that involves education, cross-disciplinary research, and stakeholders, as well as community participation. This summary is easy to write, but of course, we need to have better way how this summary can be realized, can be implemented properly at the frontline level, because all the problems usually lays at the frontline level, and then the secondary level at the district. This is the first management level to deal with this problem, and at the central level, of course, the policymaker. But for the One Health, we have also the challenge on how make to network and regional network like ASEAN network and also global network. So this is hopefully that by this symposium, we will have some understanding what is the nature of the threat and how we deal with the threat, how can we develop related intervene between the human, animal, and environment. All experts are needed here, from the researchers, from the university, and from the policymaker have to think in one direction, that we have to deal with the zoonotic disease threat in a One Health direction. Thank you very much for your attention. Thank you.
Thank you, Dr. Hayadi, for your clear and insightful presentation. We now have the privilege of hearing from our next distinguished speaker, Dr. Sowapak. Yeah. So Dr. Sowapak is an expert at the Ministry of Public Health in Bangkok in Thailand. which is, of course, deeply involved in public health policy and practice. In today's presentation, One Health practices in Thailand, Dr. Sorapak shared Thailand efforts to implement One Health at the national level. So please, the screen is yours, Dr. Sorapak.
Everyone, I hope that you can hear me well.
Yeah.
Okay, great. Okay, and thank you. First of all, I would like to thank you for the organizing committee that invite the Thailand to share one of a One Health practice in Thailand. And today I just would like to share you that what have we have accomplished on the One Health approach in Thailand, and also how we can relate it to this region. That on this morning section we can hear from the different speakers that already provide us how important often there to adopt the One Health in national level and the regional level, and also how to link to the global level. Okay, this is before we start that what we are doing in Thailand on the One Health. I would like to provide you about the national strategic plan, and then you can see here. I'm not sure that you still see my slide presentation. I hope that you see my slide presentation here. Okay, because this is okay, I will show you again. Okay, and this is the national strategic plan on the 20 year, and this is for Thailand. And you can see that we have different kind of aspects. For example, we have the goal or in the strategy how to development at our state of life to be the good quality, and also this is how we can increase and how we can make our nation in the security and people are happy. Okay, and this is important that you can see that on the a dark blue square. We say that our national strategic plan, this is the improved quality of life and ecology. So this is one of the main pillar that how we are kind of try to improve life and ecology together. So under this one, we have the first strategic for the health strategic plan that will cover from 2017 to 2036. We cover on the promoting health, preventing disease, and ensuring the excellent consumer protection. We have the strategic on the excellent services, excellent people, excellent management, and governance. So for the motto of the national strategic plan on the public health, healthy people, happy persons, and sustainable health system. So this kind of the backbone of our country, that how we set the goal and what we would like to see ourselves in the next 20 or 30 years in the future. So that means even that you look at on the slide presentation, you can see that One Health. This is one of the pillar that already embedded in our national strategic plan. And okay, and for this one, after that, after we have in the national strategic plan, we also going to the public health strategic plan for at the national level. And so we have the strategic plan for emergency preparedness. Actually, in this kind of strategic plan, it does not is not emerged during the COVID-19. But if we went back to over 20 years ago, when the avian influenza have emerged in the many countries and also hit in the Asia. And that time around in the 2003, 2004. At that time, Thailand, we developed in the national strategic plan for prevention and control of avian influenza pandemic and preparedness for the influenza pandemic. So if we look inside of the National Strategic Plan for Avian Influenza, we can see that One Health and the work within between the public health and the animal sector, and also within the wildlife, also in the proposed that in the National Strategic Plan. And then we have the second, the National Strategic Plan for Prevention and Control of Avian Influenza in the during from 2008 to 2010. And multi-sectoral collaboration is still be the major thing that we also refer and plan to get that involved with to in the operational plan. And after that, Thailand, we have in the National Strategic Plan for Emerging Infectious Disease, and then we have the next one. So on in the National Strategic Plan for EID, we have kind of the pillar under the strategy, and One Health. This is the one of the pillar under this strategic plan. The important that when we have the strategic plan at the national level, we need to endorse that to be endorsed as in the cabinet. So the prime minister will be the the head of this cabinet. When they adopt the national strategic plan, it means that all the activity, all the strategy have to be distributed and be accepted by the relevant ministry. So when we look at in the strategy of the One Health approach, how to respond within the emerging infectious disease and how we can prepare ourselves for EID. It is not only in the Ministry of Public Health or in the Ministry of Agriculture that involved within the One Health, but Ministry of Interior, also Ministry of the Natural Resource and Wildlife, and also in the other ministry, for example, like the Ministry of Foreign Affairs, Ministry of Education. They are so joy, they are so adopt that this in the One Health approach. And this is the governmental sector, but actually this is also distribute and circulate the strategic plan on the One Health approach to the private sector and with the NGO and also with the state enterprise. So that theme is kind of when we have the plan, strategic plan, it's just not only governmental sector, but different sector that join and also acknowledge about the One Health approach. That's why we call the whole of government and whole of society. Okay, and this I would like to bring you to see what in the main components. When I said that, okay, One Health approach is one pillar of in the strategic plan for EID. Okay, this we have in the 6 strategy. For example, for in the first strategy about in the we need to focus on the preparedness system for public health emergency disaster. And you can see that from in the second strategy, prevention and control system under One Health concept. Okay, that's why in this strategy direct us that how we can bring on in the different sector, wellness sector, multi-sectoral partnership to join and make our country to prepare ourselves and ready to respond after any emerging infectious disease or any health hazards. Okay, and after we have our nation Thailand adopt that in the national strategic plan for EID by using the One Health approach. We also have in the MOU. This is a one-off activity that already directed us and under the national strategic plan. We have the MOU of in the One Health among sectors. And you can see from in the left-hand side, this is kind of the paper of the MOU. And I saw the picture of the right-hand side that in the 8 organization that already signed on our MOU. They are from in the Ministry of Interior, Ministry of Public Health, Ministry of in the Agriculture. Also, we have in the university, Thai Red Cross that Ministry of the Wildlife, Natural Resource, that's meaning the related to Moroccan Health as well, already signed on the MOU. What in the area of collaboration under the MOU? We state that information need to be shared. That one, integrated operation among the sectors, and we plan to develop young generation and support the personnel in the different sectors to understand and to apply One Health approach in their operational activities. And we need to increase the level of the One Health attitude at the community level. After that, we said we have established often the coordinating health or coordinating unit for One Health. So right now, for the coordinating unit for One Health, it is located at in the Department of Disease Control in the Ministry of Public Health, Thailand. But the function of this coordinating unit is just not only focused for the public health sector, but we have the we call in the National One Health Steering Committee that combine the multi-sectoral organization, university, other ministry, and also within the forming the development partners that also join under the One Health Steering Committee. So that means any activity, any direction will be passed on the table of the One Health Steering Committee and deliver through the make a decision under the consideration of the One Health Steering Committee that the people forming the multi-sectoral organization. Okay, this kind of like one of in the diagram that show you how we using the multi-sectoral One Health coordination related to in the different sector. And also we have in the backbone of in the national plan, and then we have in the national strategic plan for EID. So it means that we involve it in the policy maker, okay, and we circulate that to on in the different governmental sector. And so we know that it is not only in the governmental sector can make coordination effectively. So that's why we link within the other development partners and also within the like a UN organization, for example, like a WHO, WOR, and also we join within the academic institution that, for example, like a CO Hun or To Hun, Thailand One Health University Network, or in the Southeast Asia University Network. So this kind of in the how we coordinate among the sector under the One Health approach in Thailand. Okay, and for the next slide, I will show you some of the activities that how Thailand we use the One Health approach to be to collect, to solve any problem that occur in the past to the future. We recognize the importance of in the preparedness system. So that's why we set kind of like a tabletop exercise and the scenario about the avian influenza. And we told the question. We asked the people that in the you see from in the on the picture, they are from in the different sector that join together and think about it, the question under the scenario. So that means we can see what in the went well, even the scenario, even the problem occur, and what in the gap that may occur during in the coordination phase. So we set this kind of the tabletop exercise regularly in each year. Sometimes it emerges from in the public health sector, but sometimes the livestock sector, they already set the scene and invite the public health sector and other sector to join. And sometimes the Ministry of Interior, they set the scenario in their province and they invite the central level to join and share the experiences. Okay, and this is another activity that in the we try to like continue the momentum of in the how we can building the workforce development. As you can see from the previous speaker that already highlighted important that we need to strengthen the capacity building of our people. So in Thailand, the same. We did the same way. Because in Thailand, when we contain the disease, we are so related. It's just not only in the public health measure or in the animal health measures, but we also have to relate it within the law and regulations. When we contain it, for example, like a COVID-19 emerges as like a pandemic around the world and also in Thailand, we have the law that we call Communicable Disease Act 2015. One of the articles under the Communicable Disease Act, we have to set in the each province have to establish the provincial communicable disease committee. Under this provincial communicable disease committee, they compose the people from the different sectors in the provinces. And one of the law and responsibility under the article of the Communicable Disease Act, we need to implement the policies, system, and the guideline of the surveillance and prevention. And the committee have to provide and support the workforce development of the people that related to under that in the health context. The health context in their provinces or in their local areas. So we have for example, we have kind of a FETP, Field Epidemiology Training Program, and in the many years ago, just only in the medical doctor or like a professional public health that in the learn under the Field Epidemiology Training Program. But we know that in the a lot of emerging infectious disease that also related to between the veterinarian animal sector. So we set the FECPV, like a Field Epidemiology Training Program for veterinary. And we know that for the disease, how to make improve the investigation on the disease surveillance laboratory is one part that we need to build the capacity. So for the after that, we have the program to increase the capacity building for the laboratory technicians. And also we know that wildlife sector is important. So we extend the training course. It's just not only epidemiological program, but add a soft skill to wildlife sector. And then we have the same cohort that different sector that join in the class. So that's mean this kind of the thing that we strengthen our workforce development. And also this good that in the training program, we work closely within the academic institution or in the research institution. Okay, that is for example to show you that when I said that workforce development, I also said in the previous slides that under the Communicable Disease Act in Thailand, we have one of the articles said that we need to establish the communicable diseases for we call it the CDCU, Communicable Disease Control Unit or CDCU. Under this unit, that means the East District of Thailand, we have this CDCU have been already established. And the component of the CDCU, it is not in the per district, it's not only for the public health sector, but we train the people from different sectors, from in the multidisciplinary to join. And for example, during the COVID-19, when the COVID-19 emerges, we also ask and request the military or from the security sector to join with the team. And we train them to understand what is the basic prevention and control for COVID-19. That is a great point, because when we can train the people from the different sector, It means that the other people can understand the concept of in the health for all or for health. It does not, when we say that like a disease, it doesn't mean that only for the health sector, but that means all of us can can improve the health security together. So that's why this is important, why we need to train the people in the different sectors to understand what is the One Health and what in the how the importance of in the whole of government and whole of society. And another thing that in the I think in the we everyone have ever like heard a lot about in the integrated surveillance or in the how we can share information, but we know that it's quite simple words. When we say that sharing information, when we say that we need to integrate the surveillance, but in the real world, so difficult. Why? Because in the each sector, they have their own authority of the information. And so we have in the different culture how to share information. And sometimes we have in the different definition when we implement the surveillance in the target population. So that means it is when we say that integrated surveillance is quite very challenging to implement that in the real world. So we know that how important, but we know that how important that in there, even though we can implement integrated surveillance and how we can share information among the sector within the transparent information sharing. But before in there, we can exhibit the integrated surveillance in the real world. The important step, this is a coordinated surveillance. So what is a coordinated surveillance? Even the any sector, they have their own surveillance, but it's good that at the beginning, the animal sector and the health sector can design their surveillance system together and can understand. That means in the animal sector, they can exhibit like the surveillance, they can implement a surveillance system in animal population by their own. But it's good to public health sector to understand what the objective, what the target of the surveillance system that the animal sector already implemented. When we join together at the beginning, this can help the sector to be touch each other, to understand the objective, to understand the target. Why that sector implement the surveillance, what information they can share. So that means it's good to start with kind of like a coordinated surveillance, and then even if any event occur, joint investigation team between the sector can deploy to investigate the outbreak. And so joint assessment is important, that we need to collect the idea of any information from the other sector. So that's why in Thailand, we have kind of like we call it the avian influenza surveillance among the protein that is in the border area, the next to like the neighboring countries. So this kind of this surveillance program that we design and we collect information and share the idea, the concept at the beginning when we start the project of the surveillance program. This is still continue on this kind of the surveillance program between the health sector, animal sector, and wildlife sector as well. Okay, and this is one important event that occur in Thailand that we call the IHR PVS, International Health Regulation, and the veterinarian service on in there. That's we need to bridge both kind of the sector together. So this is we got the support from the WHO, from WOA, from FAO to bridging of in the IHR and PVS national in the workshop. So we from this workshop in the e-sector, we can learn how we can develop in the term of the risk and public communication together, how we can make a decision, how we can solve the problems. And so this workshop can help us to identify the stakeholder regarding the mapping analysis. Who gonna be like the stakeholder under this problem, under this issue. This is important. And because from this, we can develop in the flow of communication and flow of coordination among the sector as well. Okay, and this is another point that when we have coordinated surveillance that I already told you in the previous slides, and so we need to share the result. We need to share information. What have we learned from the surveillance program? So in each year, Thailand, we have the annual One Health meeting in the collaboration within the 6 departments that you can see from the slide presentation that we present the result from the research, from the surveillance program or in the outbreak investigation. And for the matter of consideration, we also identify what in the next step, how to improve like the surveillance system or in the joint team for the outbreak investigation, and how we can prepare the resource or any like medical supplies that can respond for the future outbreak or the future pandemic in the better way. This is happen in every year, okay? And this is one picture that shows you one of the important workshop that we adopted in the joint lead assessment operational tool that by the tripartite organization, developed by the tripartite organization, WHO, WOR, and FAO. For this workshop, we use in the avian influenza. It's kind of like the one disease that we collect information from the people in the different sector to identify list, red color, orange color, or yellow color, or green color, okay? And how we can, and also we set flow of coordination. And this is great thing that we use the tool and we highlight the importance that the sector, the relevant sector, need to be joined. And the one lesson learned that we learned from this joint assessment workshop. Many participants that from different sectors, they propose to the organizing committee for the workshop. They says that this is the most of the people that join for the joint assessment. Majority of the people, 85% from governmental sector. But they said that even though we would like to complete the joint assessment for any diseases, we need to identify stakeholders and the private sector. How about in the NGO? How about the local authority need to be the part of the joint assessment? Okay, and this kind of like the laboratory that we try to set like the workflow that in the laboratory between health and animal and the wildlife sector, how we can share information, how we can communicate and coordinate if when the disease outbreak occur. So this kind of we plan to develop this kind of like SOP for and distribute to in the other sectors. Okay, and in Thailand, we have the national workshop for the One Health zoonotic disease prioritization. And this is the top 5 diseases that it does, that's good that in the sectors, they agree, okay? And now this is the top 5. And so that's mean in each sector, each organization, when they have to use the budget or allocate the budget, they can like know that the top 5 diseases that form in the multi-sectoral sector agree on this prioritization. So that means they can allocate the budget and resource in the appropriate way. For the first one, zoonotic avian influenza, then any coronavirus diseases, Nipah virus, rabies, and Ebola. Okay, this is from in the we use the tool, and this is the result from in the top 5 diseases. And this is another result of in the this is just like the example to show you that how we learn and we bring the lesson learned to develop into in the national plan. In Thailand, we have been evaluated from in the International Health Regulation that in the all indicator, Thailand can meet could meet in the the goal of in the International Health Declaration or not. And we did that in the 2022. And as you know that in the one of indicator under the International Health Declaration, they have covered the indicator about the zoonosis and emerging infectious disease. And also One Health is also one of in the main issue under this indicator. Okay, and this is what we learned. This is the best practices from Thailand. One Health is already embedded in the Thailand National Strategic Plan that I already told you in the previous slides. And also that's good that we have in the coordinating unit for One Health, and this is a focal center to gather the people from different sectors to have a discussion and to think about the solution together. And then we can develop in the prioritization of zoonotic disease by the different opinion from in the different sector. And also we have in the joint surveillance program. And also avian influenza is one of in the best good example for how we conduct the joint surveillance program. And then we have the situation awareness team that we have the flow of communication. If in any sector, they can detect any abnormal event that occur in the community. They know even that's abnormal event maybe related to in the animal population. If suppose maybe related to in the anthrax, right? Maybe related to the cattle. That means they know how to coordinate, how to share information to different people in the different sector. And so we already established the communicable disease control unit or CDCU, and that increase the cooperation from the relevant stakeholders. And we also have a regularly conduct tabletop and simulation exercise to prepare ourselves in the among the sectors. And so we have the MOU, that commitment between the sector to join together under the One Health. Okay, but we still more things to do. Okay, and this is the suggestion that what we should do to fill the gaps and to make a One Health practices in Thailand in the better way. We need to strengthen the One Health structure. And you can see that I would like to highlight the community level. So right now, when we say that the One Health, I think in the governmental sector or in the they already understand what is the One Health. But even though we go down to deep down to in the how we can make the One Health on the ground, and then the one of in the honorable speaker already spoke in this morning section. Community level need to understand what is One Health and how they can join together. So this is one that we would to highlight and can make it strengthen this activity. And so in Thailand, we from the One Health approach, we started from the zoonotic diseases. So the major player that join under the One Health approach right now is still be on the veterinarians and medical doctor or the public health officers. But we see that a lot of in the health problems, for example, insecticides or AMR or in the climate change that can become a vector-borne diseases. We need to engage the people from the wildlife sector and environmental sector to be the part of in the One Health program in Thailand. So we need to strengthen this kind of in the how we can engage those group of the people to be the part of our program. Okay, and this is to be after in the we can strengthen the One Health structure in community, how to sustain the One Health and operation at the community level. This is the plan that we need to fill for in the future direction. And also the strengthen the civilian in wildlife. This is important. And after then we can strengthen the wildlife, the civilian in wildlife, and how we can develop the platform for sharing information from wildlife to animal sector, to health sector, or environmental sector. Okay, this is the gap of the challenge that in the from in the what we learn from in the evaluation of the IHR. So, and now from all the things we have to cover like what we learned is under the purpose of the activity that right now we set for for themes like operationalize. That means we still want to like sharing the equities and how many resources between the sectors we need to sustain. And you can see that we let One Health volunteer. This is one of the future direction that we would like to strengthen and sustain. And also we know that in the and now in the global level we have in the One Health Joint Plan of Action, and also in the regional level that read by Indonesia, we have in the ASEAN One Health Declaration and also ASEAN One Health Joint Plan of Action. So that means we have to align with those action plan at the global level and regional level. And also this is important that we need to have the close collaboration on research and development among the other sectors. Okay, that is all from the One Health practices in Thailand, and thank you for like giving me, I think the representative of the Department of Disease Control, Minister Pabio, to share our practices and share experiences with all of you here. Thank you very much.
Thank you, Dr. Soapak, and thanks for our keynote speaker for that insightful presentation. So we have a little advance to the schedule, so we just take a 15-minute break before the round of discussion. Thank you. Okay, all. We will restart the session now. And we now open the floor for question to discuss about the topic present before. So this question answer session is an opportunity to explore specific points and discuss and clarify different ideas. So feel free to direct question the specific speaker or for different people present in this webinar, and let's make it interactive and enriching exchange for everyone involved. So is everyone now a specific question? Nobody? So Professor Roger Frutos here have a question.
Yes. Good morning or good afternoon. No, good morning actually for everybody. I have a question to all three panelists and to the whole three keynote speakers. One of the objectives of this webinar is to jointly write a kind of white paper on what should be proposed, what proposal we could make to the different authorities, what we have to do in order to implement efficiently One Health at the international level, so which means with a lot of interaction between different countries and a lot of interoperability. My question to all three keynote speakers is, in your opinion, what should we prioritize for this purpose?
Yes, maybe I respond first. Thank you so much for this question to our speaker. And actually, this is a very important based on the One Health concept. All the multi-sectoral cooperation is really, really important. This is the first priority. I already see that Thailand and Indonesia, you did a very good job to make the conference, made the join the working plan and made a strategic plan together with the different departments or different ministries. And this is really important for the working plan. But the implementation is more important. So when the working on the emerging infectious disease or emerging zoonotic disease, mainly particularly, because more than 75% of the emerging infectious disease are coming from the zoonotic disease. So probably zoonotic disease is really important to dealing with the strategy plan. But for the implementation, I believe the surveillance and the monitoring system is also very important implemented in the community level, in the subnational level, if possible. So these need people working together. So the second priority is the working force. Workforce capacity is very important for implementation of the surveillance system, because once if the surveillance system, if the sensitive of surveillance system is a really a good one, then you are very easy to identify the risks for those zoonotic outbreaks or epidemics. And once you find those risks, I believe the intervention will be, or we say the response will be taken place in these risk areas, and by using the different resources and integrated with the different resources from different ministries. So these are One Health approach should be take place. So these are important. Third priority is the research. And the research is really important to develop the sensitive tools for the surveillance. And the sensitive tools not only take place in the one area or one time, but also we hope this can be sustainable monitor the different risks. So the real-time surveillance tools is really important. Of course, for example, for the environmental science, they normally using the remote sensing data to help to identify the different risk areas. But for our human side, for the animal side, and those surveillance tools, real-time surveillance tools are also important to be developed. So research work, it should be make the priority on the development of the surveillance tools, which actually very still neglected. Normally, people using the diagnostic tools in the clinics or in the hospital. This is only individual one. But the surveillance tools not only for the population of human, for the population of animals. At the same time, the environmental samples also can be monitored or detected for those environmental samples to understanding the pathogen where they are. And for example, one of the important or currently using the eDNA, and eDNA can be surveillance as tools. Can develop this kind of tools, can monitor the pathogen in the environment, in the wastewater, or in the air. So these are we can prioritize in the future in the One Health working plan or activities. So I would like to mention these three priorities now. Thank you.
Thank you very much, Dr. Zhu. So maybe Dr. Swapak or Dr. Aradi have something to add?
Okay. Can I have my turn, please? Hello?
Yeah, please.
Okay.
Yes.
Yeah. Since the question is related with the global aspect, so I would like to bring some background that now the mobility of people are quite intense, not only in country, but regional traveling is very massive. Just use an example, we can have a breakfast in Jakarta and then have a lunch in Tokyo or dinner in London. And this situation make the risk of transmission of any kind of disease threat is become bigger and bigger. So for that, we need to have common understanding about the risk assessment, cross-border risk assessment, or regional risk assessment, copying the WHO mechanism that each country, they have the IHR national focal point and also the regional focal point. Is it important to have the national One Health focal point and the regional One Health focal point? The purpose of this focal point is like a gate for one gate communication between member or each country in sharing the information and sharing the risk of transmitted zoonotic disease from one country to another. This is very much related with the some kind of MOU, what kind of information could be shared between one country and another. The concept of indigenous and importation now becomes more clear. What do you mean with the indigenous case? What do you mean with importation case? Because as I mentioned, mobility of people is very massive. So one is the risk assessment. The second is like a common organized work. What kind of surveillance can we develop? Because each country have different priority. For one disease important in one country, maybe less priority another country. But the risk of transmit from one country to another country is critical. So sharing information from one country to another country is important. However, in terms of security, sharing information is not that freely, but we have to identify what is the mechanism could be shared between one country to another country. Because I'm sure that in each country, they have a regulation, what kind of information could be shared. The third one, I agree that research is important because how to identify the problem, how to identify the mode of transmission, which is from country to country, or with the nature of the agent itself is changing. For example, for some disease from the one type of transmission become environment transmitted and other. So research is important to identify what is the most risk for transmit from one place to another place. The number 4, the human resource investment. Human resource investment is important because if people knows about the threat and they know how to implement the One Health approaches, it's important. Otherwise, they will work solely from human health, work in their area. The animal health will work on their area only. So the collaboration under the One Health approach should be well defined in each country and could be implemented at the frontline level. Thank you. I think that's what I can give a response for that.
Thank you, Dr. Aryadi. So, Dr. Sarawak.
Okay, thank you. And I agree for the both speaker that already highlight the important issue that in the how we can prioritize. And I just would like to add just in the additional point that in the how we can like prioritize on the One Health approach in the our region. Okay, for in the first one, the important that in the we have to think how we can sustain budget. This is important, and how we can use the budgets to implement the activities. I think the most often the activity right now is still depend on the governmental budget. So that means we have to convince the policymaker to understand the One Health approach and how we can convince the policymaker. So the landscape, the global like a geopolitical landscape, this can be driving factor for the policymaker. As we know that that's great that at the global level, we have in the One Health Joint Plan of Action. That's meaning all the members of under the UN, we can use that to guide. And also that's great that in the regional level, in the ASEAN 10 member states, we have in the ASEAN One Health Joint Plan of Action as well. And also this already endorsed and committed at in the ASEAN Summit. So this can be like another driving factor to tell the policymaker in the East country, okay, we have to align within the global agenda. Okay, this is a one. So that means when they go to like in the national level, when defend for in the like a below budget, so we can have more budget to continue and implement activity, because in this already addresses at in the global agenda or the regional agenda. And then at in the intermediate level, we need that is like a researcher, academic institution to translate what the activity that they already implemented in the community and what we learn. It is not only like only for the real scientific research, but it can be like a social behavior, the result, or the any things that in the what we learn from the community is we can pick that like a model, and we need the researcher to be like an intermediate person to tell, to advocate with the policy maker. Okay, and now what in the we conduct this research in this community, and then we need to expand. So we need this the intermediate person to tell between the community level and policy maker to expand what the best practices are in the One Health. And also community level, this is important. So that's mean because in the all often the activity or in the any research, even though we would like to implement community participation, this is a key factor. Even though we would like to success or compete on the our research or in the any activity, even though we didn't get any like acceptation from the community, it's hard to accomplish it. So community participation by engage them and make them understand what is the One Health. This will be important. So that's why I think if we cannot just highlight only one by one, but on the pathway, policy maker, intermediate person like a researcher, and community participation. This is important when we have to do all the things all together. Okay, thank you.
Thank you very much. So, Roger says thank you. So if anything, have something to add to this specific question?
May I?
Yeah.
Okay. Thank you, moderator. I am Mugi Wahidin from National Research and Innovation Agency, Indonesia. I would like to ask to Dr. Suapak from Thailand. In your slide, you have a recommendation for the activity of One Health program in maybe in Thailand or in other countries that you recommend to strengthen a collaboration research among all members. So my question is, what are the research you have conducted in your country, and what are ongoing research or planned research? And what is your suggestion about the most important research about One Health? Maybe we can implement it in ASEAN countries. I think that's the question. Thank you.
Thank you for the questions. And the first one that in the what in there any ongoing research on the One Health that in the we are already implemented. Actually, we have a lot of in the research that in the joint collaborated between in the governmental sector and also within the university. Okay, like Mahidol University or in the Chulalongkorn University. And one of in the program, I would like to say that the program, research program that already been ongoing research right now. And now in the we are going to the second year of the program. This is we have like a sub project under this program. We call it the integrated research on in the One Health and in the zoonotic disease and emerging infectious disease, but I cannot remember the full name. But under this, we like the line, the story. This is about in the any issue related to emerging infectious disease. And for example, we join within the I think the one of speakers said about the something that's important like a wastewater surveillance. I think the Dr. Shu, right? That in the we need to conduct this kind of like a wastewater surveillance. And this is what we learned from COVID-19 that in the some country have like a can predict and can detect like early outbreak, like a detection by using the wastewater surveillance. And also when mpox emerge, we also in the see some the country use that kind of in the proxy to detect that in the outbreak. So right now we have implemented like a wastewater surveillance in like in point of entry in the some proximity. It's like in the some facility to detect that kind of in the any emerging infectious disease. As we know that from the public health sector, we just have like some really like a few experiences on the wastewater surveillance, but the university and also within some in the Department of Environment from in the other ministry, they have like a full experiences of in the wastewater surveillance. So we join together and it still help like we can detect some like a COVID-19 and also impacts on the wastewater. This is the one thing that we use the research kind of like the thing that how to collect the expertise from the sector to join and being the result to in the policy maker and being the result to get into the routine system that how we can alert what the result show. This is kind of the thing. And what in the priority of the research that we can set the agenda. I think it depends on in the local context. So that means we would like to support in each province, each area, each country to do kind of like a list analysis. And list analysis, it should be like a joint list analysis. That means that we can see that sometimes maybe there's some disease that never been prioritized in the public health sector, but animal sector, they know well. Even it can be like a really high list of the disease it can be the potential zoonotic disease. So that means that each country, each region of each area should do their own like a joint risk analysis and identify the list, the prioritization. And then after we know the list like a prioritized hazards or the list of the disease, and we can do the further research that match what in the list analysis show. I think this is important. So maybe it is not the disease, but it's good to have this analysis. And the one gap that we found from in the list analysis, maybe from in the prioritized zoonotic disease, because you can see that when Thailand show like the top 5 is based on the disease pathogen, right? But we know that the climate change, we know that in the some environmental factor, it can introduce for the hazards or the disease as well. So that means when we prioritize the list, we have to gather information. It does not only pathogen, it does not only in the animal or human population, but we have to think about in the climate factor. We have to think about in the environmental factor as well. So that means it can be the great job for in the list analysis. And then we can continue to in the any further research. Thank you.
Thank you, Dr. Swapak.
Thank you. So anyone wants to ask another question? Yeah. Okay, I have one. It's not an easy one. So it arrived to me during Professor Zhu's presentation, but it could be addressed to all people. So Professor Zhu, you highlight that expected benefit to a substantial investment in prevention within One Health framework. So the challenge is that, and we see that many times during years, is that the successful of prevention results in an absence of outbreak, so an absence of visible cost. So this lack of visibility outcomes can lead to a public and a policymaker to reduce investments in preventive measures, and consequently, the prevention is often neglected years after years. So, do you believe that there is a way to maintain the vigilance in the medium and long term beyond simply waiting the next inevitable pandemic and to start again to increase a new time the investment?
Yes, maybe I respond first. So this is very important for government or policy makers promote the One Health concept by using the different kind of resources together, and also it should be put more efforts on the One Health implementation, because as you say, the prevention first. So how to prevent the emerging infectious disease, and this is a really important issue. So for the academic level, we need to identify the pathogen first. Then the pathogen where you can find at the earliest stage for the pathogen identification. Its examples should be come from the environment, come from the animal waste, or then maybe can more prevented from emerging infectious disease to affect to the humans. So these efforts actually not only the Ministry of Health issues, but it is also should be incorporated with other ministries. And I believe the resources from different ministries are differently, and how to coordinate those resources together is a very important issue or essential issue for our One Health activities or for One Health actions. So this, if we raise these questions for preventive next pandemic or preventive disease X, this concept goes to the cabinet of the government. This will be more efficiently to coordinate these kind of resources and to be used in the One Health action. This is my thinking and my suggestion. Thank you.
Thank you. Dr. Swapak, Dr. Ariali, you want to add something?
Yeah. Yes, I agree with what Dr. Zhu mentioned. I need some additional statement because discussion among the professional is more easy, whether the researcher, whether the educator from the university, from the animal side or human side is more easy since we are the professional working on daily basis with our disciplines. The problem now with the the authority, which is non-health or non-veterinarian or others, they think from different angle. So to convince them, to convince the understanding about what is the threat, we need to convert the language from the scientific language into the more operational, let's say from the economical language, because for them it's more easy to tell them that if you don't do this, you will lose the money like this. So investment 1 billion will protect to have lost 10 or 50 billion in the future. So without ability to convert it from the technical language into the more common language, this is a barrier because they have their own priority in their mind, what is more important from their angle. So again, I would like to repeat that in each level, like for Indonesia with the decentralization, each district have their own power to decide which one is important, which one is less important. So dealing with the medium authority is a big challenge. But on the other hand, at the center level, talking with the cabinet, again, understanding about what is the meaning of zoonotic disease, they don't have something in their mind. So when we try to convince what is the importance of preventing, then curative is another challenge, because in their mind, find the case, treat the case. It means curative side. But how to protect people from the getting the disease, something is like imaginary. So we have to convince what is the risk factor in a common language. But basically the concept that we need to socialize, we need to have better advocation about the risk to the other than professional. Thank you.
Thank you, Dr. Ayadi. Dr. Sawapak, do you want to add something?
That in there additional comment regarding the already both our speaker already in the address or the thing, and I just would like to highlight that in the one of in the training course or in the workforce or like a development or in the how to build the capacity for in the capacity for in the different sector is a soft skill, but it's very important. It's a policy advocacy. Because then there's sometimes even though we cannot translate what in the result in the research, what in the important that in the we would like to advocate the policy maker, and even though we cannot practice that, we never practice that, it's hard to talk within the policy maker. So the policy advocacy is important soft skill that we need to develop. And because that when we can convince the policy maker, so that means that we can create the environment of the sustainable for the project in the long term. So this is important one. And also we need to think about in the because in the we have I have like some one experiences when I talk about the what is the benefit of One Health, and my like a big boss at that time, he asked me, and what did the people get from the your project on the One Health? Okay, what the people get? Actually, in the some indicator, we said that okay, we can decrease up in the incidence of the disease. We can prevent up in the mortality among the people. So even the One Health is kind of like for the prevention. Maybe it's hard to say and convince within the policy maker to compile what in the we would like to do or how we can receive the budget to implement activity. So I think this is the thing that in the we need to even the any maybe in the for in the I know that in the most often the academic institution here, maybe it's good that in the we can think about in the how we can like train the people more understanding and can practice well for the policy advocacy. That is important thing. And so it is not policy advocacy, but how we can convince within the community, local authority, agree what in the how the benefits of the One Health. So I think this is a 2 points that in the we can strengthen. It does not only in the national level, but regional level, global level. Need to think about this, how we can train the people, make in the workforce development, build the capacity for the people. Okay, that is all for my comment. Thank you.
Thank you all for your answers. So anyone wants to add something about this question in the audience? No. So there is another question. Just check on now. Nobody? No, I have no other question. So thank you very much. And thank you for our speakers and for this interesting and very stimulating discussion. So we next session is at 1 p.m. Lunch break now, and let's move to our next session at 1 p.m. for Jakarta time. It's about One Health program in Asia. Thank you for your participation, and thank you for our speakers.
Thank you very much.
Thank you very much.
Bye-bye. Thank you. Bye-bye.
Bye.
Good afternoon, everyone. Welcome back to our webinar. Yeah, we hope you had a restful lunch break. Now let's dive back into our discussion. I am pleased to introduce our moderator for this session, the esteemed Dr. Mugi Wahidin from the National Research and Innovation Agency BRIN. To Dr. Mugi Wahidin, the screen is yours.
Thank you, Bu Dea. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Ladies and gentlemen, now we are moved to the first session of this webinar, the International Webinar Seminar One Health, One Move, Breaking Barriers for a Coordinated Implementation. This session is about One Health program in Asia. As we know, we are facing a serious threat of disease spread across the world caused by animal-to-animal transmission, followed by the animal-to-human transmission. Plus, pandemics of COVID-19 prove us that the public health problem due to One Health, related to One Health, is very serious. And we know also that 70% of the pandemics is caused by zoonotic disease. And One Health is a collaborative approach incorporating health sector, veterinary, environmental areas, agriculture, and other sectors that should be collaborated each other. And there is also an agreement between WHO, WHOA, and Food and Agriculture Organization to develop One Health activity in the world. And Asia is the biggest continent in the world, contributing more than 60% or more than 4.7 billion population in the world. Furthermore, the risk of this disease is also high in terms of vector-borne disease or airborne or direct contact disease. And it is more higher due to the high mobilization across the countries. Thus, this session is very important part of the webinar for us to know what the program in ASEAN countries in terms of One Health. Ladies and gentlemen, there will be 12, I think it's very big number, 12 speakers in this session, consisting into subsessions from ASEAN countries and beyond. The speakers will be from Thailand, France, Indonesia, Morocco, Vietnam, Laos, and China. And ladies and gentlemen, we will start our session. The speakers will speak for 20 minutes each person. Yeah? And the first speaker is Professor Tirapap Charon Firiapap. I'm sorry if I'm mistaken for the spelling. He is a professor from Kasetsart University, Bangkok, Thailand. He will be speaking entitled Non-Human Primate and Human Malaria, One Health and a Control Perspective. Professor Tirapap, the time and screen is yours. Please, Professor.
Thank you so much. So can I start now?
Yes, please.
Okay. Can you see the screen now? Good afternoon, everyone. First of all, I would like to thank Professor Roger for inviting me to the conference on One Health, One Move. Today, I will speak about non-human primate and human malaria on the context of One Health and a control perspective. My outline today include the background, mosquitoes and mosquito-borne diseases in Thailand, non-human primate and human malaria, vectors of malaria and implications, vector control tool, spatial repellents, or we call HR, and perspective. As you know, One Health is a holistic approach to systematically understanding the complex relationship among human components, animal components, and environment and climate that have a great impact on well-being of human population. Vector-borne diseases account for more than 17% of all infectious diseases caused by disease transmitted by diatomaceous bug, leishmaniasis by sandflies, scrub typhus by chicken mice, tick-borne encephalitis by ticks, and many other more. Now let me talk about the mosquitoes and mosquito-borne diseases in Thailand. There are at least 436 species of mosquito in Thailand. 78 species belong to Anopheles mosquito. 164 species are Aedes, and 144 species belong to Culex. This slide shows you the two most important vector-borne diseases in Thailand, which are malaria and dengue. As you can see here, Thailand has a long history of malaria. Malaria cases have decreased significantly from 2012 until 2021, and cases start increasing in 2022. In 2023, there were 16,000 cases and still high in 2024. Besides malaria, dengue cases reached a peak in 2023 with 150,000 cases, as you can see from this slide. Talking about human malaria in Thailand, cases of malaria has been reported mostly from the international border between Thai-Myanmar, Thai-Malaysia, and Thai-Cambodia. Human malaria parasites have two different hosts, humans and mosquitoes. Besides human malaria, simian malaria affects several countries in the Asia-Pacific region, including Thailand, Cambodia, Vietnam, Malaysia. The transmission cycle includes human, monkey, and mosquito. So far, there is no information about passage of monkey malaria parasite from human to human by mosquito. This work needs to be done soon. As mentioned in the previous slide, simian malaria had been reported in many countries in the Asia-Pacific regions, primarily by Plasmodium norisci. However, in Thailand, all four simian malaria parasites were reported, namely Plasmodium norisci, Plasmodium Cynomolgi, Plasmodium inui, and Plasmodium ferdi. This slide shows the cases of Simian malaria in Thailand, which started increasing in 2017 and reached a peak in 2023 with 275 cases of Simian malaria. However, there were 80 cases of Simian malaria in 2024. As you can see here from the slide, not only were provinces along the border between Thai-Malaysia found positive for Simian malaria, but some provinces in the west and in the east coast of Thailand were also positive for Simian malaria. Study on genetic population of Plasmodium norisci during pre-malaria elimination in Thailand have shown similar genetic background as those isolated from Cambodia and Malaysia. The complexity of non-human primate malaria is not only mosquito that shows species complex that I will talk later, but human and monkey physiological profiles and behavior are also complicated. These three hosts, mosquito, monkey, and human, share the same similar parasites, which is interesting to explore in the near future. Let's talk about mosquito vector. I would like to start first with the Dirus complex. Only 5 species of Dirus complex have been found in Thailand. Anopheles dirus, Anopheles bimai, Anopheles crucian, Anopheles nemophilus, and Anopheles scannoni. But only Anopheles dirus and Anopheles bimai are considered as the vector of malaria in Thailand. And 2 species in Leucophorus complex, Anopheles latens and Anopheles intoratus, which are not shown here, play the key role in Simian malaria transmission, and these 2 species have been found in the southern Thailand. For the Anopheles maculatus group, among 8 species, 7 species had been reported in Thailand. Some had been incriminated as vector of malaria and some are non-vector. Vector of malaria include Anopheles maculatus, Anopheles pseudovimoli, Anopheles swativongporni, and Anopheles wilmori, as you can see from this slide. Anopheles minimus complex and genetically related species. 5 species had been reported in Thailand, and these include both vector and non-vector. As you can see here, we have Anopheles minimus spread all over the countries, and this Anopheles minimus is a vector of malaria. Anopheles aconitus, another one in yellow, in the yellow black here, you can see this also is considered as vector of malaria in Thailand. For Barbirotis complex, this complex is very interesting as we don't know much about the role of each single vector, each single species. In addition, Anopheles epiroticus play a significant role in malaria transmission along the brackish water and beach area. This slide is very interesting that I would like to show you here about outdoor transmission. The slide shows the behavioral traits of Anopheles mosquitoes in Thailand identified by molecular techniques. As you can see here, important vector like Anopheles minimus, Anopheles harrisoni, Anopheles dirus, Anopheles bimai, maculatus, and Swartivong 9 are outdoor biter. This outdoor biter links very closely to the residual transmission or outdoor transmission. And this outdoor transmission is difficult to control because of the absence of effective vector control tools. As no specific drug or effective vaccines are available for malaria, vector control remains an important measure to control malaria. This is a list of some available tools that are used for mosquito control, including insecticide-treated nets or ITN, extractive targeted baits, salt reduction, vector traps, genetic manipulation, SIT combined with microbial infection, topical repellent, and spatial repellent. Each one has pros and cons and some limitations. Today, I will talk about the spatial repellents. This model will show you the action of the spatial repellents or the SR product if the house treated with the SR compound. And this compound works well. Mosquito will not enter the house and protect against biting. Some of the SR products for indoor and outdoor use are available in the markets. All SR products are pyrethroid-based, but with a mode of action not intended just to kill mosquito. The volatile chemicals repel mosquito from entering the treated space and disrupt their ability to detect or bite human. At least 2 study sites, Thailand and Peru, were conducted to study the efficacy of SR product. The study used semi-fused greenhouse system and the experimental hut to evaluate the efficacy of the SR product against mosquito vector. Some publications are reporting the study of SR product under the semi-fused greenhouse system and the experimental hut. The most effective compound belong to the pyrethroid groups, especially tranputrin and metroputrin. Several SR products are available for indoor use to protect the indoor biter like Aedes aegypti and Culex mosquito that bite early of the night. Very few SR products had been studied for outdoor use to protect against outdoor biter like malaria vector that prefer to bite outdoor. So let me conclude with the perspective. Non-human primate malaria is a growing concern in Thailand as evidenced by an increasing number of positive cases in recent years. Therefore, enhanced surveillance should be implemented to cover all at-risk areas comprehensively. Outdoor transmission poses a significant challenge for control program, as no fully effective tools are currently available to use. Spatial repellents have shown potential as effective tools against vector-borne diseases, and most SR products are commercially marketed to consumers. The most important ones about the epidemiological evidence. This evidence on SR study is essential and need to verify their effectiveness within disease endemic area or the disease prone areas. Thank you for your attention.
Okay, thank you, Professor Sirapap, for your very informative presentation. For the participant who would like to ask, please wait, yeah, because we have another speaker before we open the question and answer. The second presenter is Professor Roger Frutos. He is from Sirat, Montpellier University of Excellence, Maydol University. Professor Roger, please the spread yourself.
Rogers, you have to unmute.
Okay, sure. Can you see it? Can you hear me? Yeah, okay, very good. Yeah. Yes. Okay. Yes, it works. Thank you very much. Thank you very much, Mr. Chairman. So what I'm going to do is talk briefly about a very specific situation, which is the animal-human interface, which is a very important point in the dynamic of the transmission of infectious diseases. If we consider infectious disease, what is an infectious disease? Actually, an infectious disease is just an epiphenomenon of the population dynamic of the microorganisms, or in other words, the infectious agent. An infectious disease is not a tangible biological entity. It doesn't have a real existence. It is a perception. It is the visualization of the incapacity of part of the population, host population, to resist the damages resulting from the life cycle of the pathogen. These damages are what we call the symptoms. And since the disease is just an epiphenomenon of the dynamic of population, the key factor at any stage before the disease and after the disease in the epidemiological phase is what we call the R-naught. So basically the ratio, the capacity of transmissibility of the pathogen. Transmission from one host species to another is a stochastic process, is ecosystemic, is driven by many different small conditions, and which are coordinated in a stochastic way. Some may happen, some not the same time, not the same way, and we don't know exactly how it will happen. It's extremely stochastic. It means it depends on the environment. But basically, you must have a first contact. Then once the first contact is established, the pathogen, or particularly the virus, must enter the cell, and be able to replicate into the cell. And once this is achieved, it must then diffuse into the new host population. So it's a very complicated, slow, and discrete and stochastic process. What is important to realize, especially with what we talk about viruses, is that we have a global circulation of meta-populations of viruses. And humans are just a part of this global circulation. The virus is a separate realm, and the virus can infect different hosts of different species, mostly based on the presence of the relevant receptor, and if he has affinity for that. And it can move from any direction, from animal to animal, from animals to human, from human to animal, the human species being nothing else than another animal or species. So there is nothing special about it. And we participate to this circulation. Of course, when the virus comes into the human population, we are interested in, and we start a process of evolution of the virus within the human population. But there is absolutely no magic. Infectious diseases are not transmissible. As I said, the disease is not a tangible biological entity. A disease cannot be transmitted. A disease is just the consequence of the dynamic of the virus. So there is no magic. There is no spontaneous generation. And anything must come from somewhere. So if a pathogen appears in a new species or new population, for instance, the human population, it is because it was transferred from another species. So pathogens are circulating from host to host, and depending on the host, they may trigger different diseases or not, because it could just be a commensal, or the individuals might just be asymptomatic. So there is therefore no disease. However, there are some mandatory conditions for that to happen, because for a pathogen to emerge in the population, and perhaps later on a disease also to emerge in the population, there must be a transmission. If no transmission, therefore there is no emergence and no infection, no disease. But for a transmission to occur, there must be a contact. If no contact, no transmission. And for a contact to occur, there must be what we call an interface. And what is an interface? An interface is a place shared permanently or frequently by different species. And so they share the same habitat. So it's a matter of habitat and dynamic of populations. Host population that can transfer a pathogen from one to the other. If we are talking about medicine and human diseases, the main driver is very simple. It's the human population growth. Because if you look at what happened, for instance, at the very beginning of the 20th century, we were maybe 1.5 billion humans on Earth. Today, we are 8 billion. So, of course, the density is bigger. The contacts are more numerous. We occupy the same land as other species. So, therefore, we colonize the wildlife habitat, because we need to build houses, we need to live somewhere, okay? But in turn, the wildlife that will colonize the human habitat. And that's where we have an interface that comes into the game, because we have then an interface because our habitats are overlapping. If we have an interface, then we can have a contact. If we have a contact, then we can have a transmission. And we have a transmission, then there is a possibility of infection. And so that's a very essential point in One Health, is that we need this interface. And what is the most frequent interface? Actually, that is the place where humans are in contact with wildlife, with animals. So basically, it's mostly the rural areas, villages, farms, fields, okay, which attract a lot of animals, or the pioneer front, when we create new suburbs right in front of the forest, where we can create some contact. It's never in downtown big city. It's always where we have this interface. So there is, therefore, because there is the is linked to the human development and human population. Therefore, there is a societal dimension to it, by definition. Okay? And it's very important also because the societal dimension is the only one on which we can do something. We cannot prevent a pathogen from evolving. We cannot prevent viruses or other pathogens to move from one host to another. So the only thing on which we can help doing something is on ourselves and is on the societal dimension. And what is important to realize is that pathogens, whatever pathogen you are talking about, they always use the ecology of the host for dissemination. And they take advantage of it. Sometimes they even manipulate it. And human viruses, they circulate and evolve within the human society once they have entered the human population. And what is the human ecology? By the ecology of the human species is simply what we call the human society. And the ecological rules of the human society, the human species are what we call the societal rules. Okay? So the way things we can control we could prevent the distribution and the spread of viruses or other pathogens are basically societal rules, which means that it's not biology, it's not medicine, it's a matter of political will. It's a matter of society. So what we need to do, and we can do, we should, and we can actually, is preventing contact at the interface. That we can. It's just a matter of organization of the habitat, of the quality of the habitat, to make sure that there is no overlapping of the different population. It's a matter of local management, a matter of people awareness. It's what we call the behavioral management, which works only at the community level, small village or small neighborhood, where people can avoid the permanent or frequent overlap and share of the space, so the interface. So basically, very quickly, if we consider the whole dynamic of a disease from the first contact to the emergence of the disease itself, we are going through different steps of biological and societal nature. There are basically two steps where we could do something. One is the amplification loop, the societal amplification, what we call a cluster. Is when the disease emerges. That is very difficult because it's not well accepted by population. It's quite difficult. It will be a lot easier to control it at the level of the primary case. In other words, when the first human or the first group of humans is put in contact with a new virus, and this happens mostly in rural environments. And in that case, there is something we could do, mostly by improving the habitat and preventing animals from invading the human habitat as well. So, which also turns into improvement of the habitat, which is well perceived. And that's more or less the only thing we can really do efficiently. And if I was talking about viruses like SARS-CoV-2, COVID-19, for instance, or other viruses of that kind. But this is true also for vector-borne diseases. But in the case of vector-borne diseases, the main target will not be the virus, for instance, but rather the vector, the mosquito or other vectors. One very important disease is dengue, especially in Southeast Asia and elsewhere, is the disease which is really booming. And dengue is typically an anthropogenic disease. The human society is responsible for the spread of dengue. Especially when you look at it simply at the origin, the virus is Asian, it's actually coming from here, okay? But the main vector is African, so it doesn't make sense. It makes sense simply because the virus was put in contact with the vector because of human activities. Actually, the main vector today vectoring dengue was put in contact with the Southeast Asian virus after the opening of the Suez Canal. So it's a matter of trade, it's a matter of movement of goods, of transportation of mosquitoes by boat, etc. So it's really a matter of human activity and human society. And for instance, a disease like dengue cannot be tackled if we don't consider human activities. It's absolutely essential. And even worse in the case of dengue or chikungunya, by the way, which is because it's the same vector, is we have a change of paradigm in that. We have today, and for let's say the last 40 years, we had a global economy. Any goods are traveling all around the world, and doing so, we moved mosquitoes all around the world. So mosquitoes, which are potential vectors, are present all around the world. They are not necessarily infected, but they are vectors. They are present everywhere in the world. But our modern society is characterized by the fact that we travel a lot by plane, and we move from one side of the planet to the other within 24 hours. And there is a high mobility of people. And people can be infected in one part of the world, carry the virus to another part where they are in contact with local population of mosquitoes, which can then get the virus and infect local populations. With the Aedes-borne diseases, we have something very interesting, is that the paradigm has changed. It's a vector-borne disease, but it's mostly the humans who have become the vectors of the virus, not the mosquitoes. Humans carry the virus and infect the mosquitoes, and later on the mosquitoes infect the local population. So again, the human society is a key issue. And problem we have with, for instance, dengue and Aedes borne diseases is that there is no predictors we can use. Of course, WHO is recommending what we call the stegomia indices, but they don't work. They simply don't work. There is simply no correlation between any kind of the stegomia index, the Breto, the House, or the container index. Zero correlation between any of the index and the incidence of dengue. Absolutely none. So it's not possible to predict or to assess the risk of dengue just by looking at the mosquito population. It doesn't give us no idea. They are not reliable indicators. So we have to do something different. What can we do else to control? But the only thing, and Professor Dapat mentioned that before, the only thing we can do, especially with dengue and other diseases, is vector control. But in the case of Aedes, either aegypti or albopictus, our possibilities of action are extremely limited because of their life cycle, their way of life is extremely difficult to treat every breeding site. We don't even find the breeding sites. So we cannot control, even if we have means. So I eliminate chemical insecticides because of resistance and pollution. But even if we consider biocontrol, so Bacillus israelensis, or BTI, which works extremely well, we cannot put it on every site, every breeding site. We cannot identify them. And when we have other ways of controlling, whether the Trabase, Ovitra, Wolbachia, etc., they work only partially. Okay, so when it comes to dengue vectors, we don't have any technical solution which work well. The only solution we can rely on is what we call the integrated behavioral management, and at the community level. So again, we come back to the human society. And it's the people in the community who have to control it, they can't control it. So it must be done at the community level. It's mostly a matter of people awareness, so education. Of course, it's community-driven, and it's very important to consider that the problem, for instance, of dengue is global around the world, but the solution is local. We need to achieve the solution by adding local solution. Each one control at the level of the community. It's the only thing we can do. And something, for instance, the work we did in Indonesia, we found out that dengue is not distributed evenly everywhere. We have clusters. We have places within the same city with dengue and other places without. So we need to find out how we can do that. Good, I have time. So now our solution to that is what we call e-dengue. So I will just show you the... it doesn't work. Bon, I skip it because I don't have the sound. Sorry. So basically, we develop a platform for that to bring the means to people to control. And there is no single universal approach. What we need to do is to consider different approaches together at the community level and give the people the possibility to act at this level. It's really a strategic approach. And how can we prevent dengue outbreaks and other diseases which are not vector-borne is really a problem of society and is not a problem of medicine. And for that, we need really sociologists, architects, urbanists, modelers, policymakers, and mostly what I call the middlemen. In other words, people who have who can make sure that we have a sustainable implementation. And these people are leaders, wise men, teachers, clerics, who can play a very important role. So again, we come back to a societal aspect and an anthropological aspect to be able to control this disease. And so as a conclusion, I would say, what is One Health? One Health is really to consider the true position of humans, the true nature of diseases, the true dimension of pathogen, the true understanding of the dynamic and the key role of the society and human pressure in the emergence of propagation of infectious disease. It's a lot more than just a medical problem. I will stop here and thank you for your attention.
Thank you, Professor Roger. I think it's very important that animal and human are interfacing each other. Even every day, we are not living alone. We live together with and contact with animals, plants, and others that make they are a source of disease or host of disease that can transmit to human and other animals. Ladies and gentlemen, please hold your question until we read the speakers, the 6 speakers. Yeah. Bapak Ibu, ladies and gentlemen, the next speaker is Professor Triwibawa. He is from Universitas Gadjah Mada, Yogyakarta, Indonesia. He will be presenting the Global Health Consortium Indonesia and One Health program at Universitas Gadjah Mada. Professor Triwibawa, can you hear me? The screen is yours, please. Professor Triwibawa? Can you hear me? Let me check. Yeah, I think he is in the Zoom meeting. Debri, please.
Hello. Sorry. Thank you very much. I was not invited as a panelist, so I cannot share my screen and I cannot talk now. Can you invite me as a panelist?
Wait a minute, Professor. Debri, please.
Okay, Pak. Sorry.
Professor Triwibawa.
Already Pak Triwibawa.
Okay.
Okay, thank you very much. Then I can talk to you now. But thank you, Mr. Moderator. So, first of all, good afternoon, everybody. Thank you very much. It is an honor that I able to join this precious meeting. And I was contacted by Professor Roger Frutos to join this meeting, and then I will presenting something. I will talk about Global Health Consortium in Indonesia and also what is One Health program in our university. Okay, can you hear my voice, Pak Mugi?
Yes, it is clear.
Yeah, okay. Can you see my slide?
Yes.
Yeah, okay, thanks. Yeah, this is the outline of my talk. Of course, I will describe what is the Indonesian Global Health Consortium, and the second thing I will talk about the One Health approach implementation in our university, Universitas Gadjah Mada in Yogyakarta. Then, what is the Indonesian Global Health Consortium? It is a consortium that is established last year in 2023, and it is included certain university. There are 6 university: IPB University, Universitas Airlangga, Universitas Gadjah Mada, Universitas Hasanuddin, Universitas Indonesia, Universitas Udayana, and also National Research and Innovation Agency, or BRIN. Thank you very much, Roger Frutos, to also helping us to establish this consortium. Though it is named as Global Health Consortium, it is sound like a human centrist, but still we are talking about One Health here. And then what is the aim of this consortium is to establish the collaborative partnership among the parties, and it is also aimed to participate in a coordinated and collaborative manner in meeting the demand of projects, especially for research project and also implementation, both in national and international level, as well as international and national research activity in the global health and also in One Health, of course. The next is that the aim of this consortium is to exchange information related to the demand of project, conference, discussions, seminars, and also scientific reunions organized by any party. And then, of course, we will notify each other about this activity. And then the last but not least is that we also possible to have another cooperation in terms of One Health research, development, and also One Health approach implementation in our society and also in our university and institution. Why we need this collaboration is because we know that there are many health problems in Indonesia that need to be anticipated using the One Health approach as one of that like described by previous speakers, and also Prof. Frutos just highlighting about the dengue and other problem like zoonotic disease. Of course, we have that emerging and re-emerging disease, vector-borne disease, dengue, chikungunya, malaria, antimicrobial resistance that we also recognize as one of the silent pandemic. That is, our country have the very serious problem with the antimicrobial resistance. And then the food safety and security. We have a problem when we trying to change our woods, our forests becoming the monoculture for food, for example, then it is going to be problem also for health security. And then environmental pollution, like we have microplastic and also the climate change that is very high, very troublesome for us, and it has related with our health, especially in human, animal, and environmental health, and also many other chronic disease that is related with One Health also, like cancer, for example, or other degenerative disease like chronic pulmonary obstructive problem, for example, that is related with air pollution and also other problem. And then also frequent disaster. Geographically, we have many landslide, many earthquake, and other flood, also other disaster that might be happen in our neighborhood, in our community. Then we need to also preparing to the disaster preparedness and response. So at least I brought eight topics that might be really suitable when we thinking about with the One Health approach. And then I bring this slide is just to make sure that you are realize also that this is the implementation of One Health approach in our country, especially for the antiviral resistance. And not only us in Indonesia, but also there are four world organization that is joined with us and helping us. And of course, because this antimicrobial resistance is really troublesome, and the the problem is quite huge in Indonesia and also global. So One Health approach is the only way where to solve this problem, especially because the antimicrobial resistance is related with the use of the antibiotics and also other antimicrobial in human sectors, and also the animal sector, and also in the agriculture and environmental. Yeah, this just is example that actually One Health approaches really neat, and it is already implemented in Indonesia. And then the challenge, why we when we trying to apply the One Health approach in Indonesia, and also I think it is the same problem, same challenge also happen in other part of the world. So that's why we need to have a consortium to tackle down this together, because if we have many resource and then we have many power, of course we're going to increasing our ability to tackle down this challenge. The first is the approach and communication. When we talking communication, like the keynote speakers that this morning saying that the communication is problem because we are sometimes working in silo. I am an MD, so my mind is only the health of the human. And another vet, my colleague also we talking about only the animal health. And the environmentalist maybe, or agricultural expert, they only talking about the agricultural thing. Then we try to communicate each other. We use different language actually, because I cannot explain my mind to my colleague that is working in agriculture, because I'm using medical terminology that is not understood by them, and vice versa, because they are talking in their language I cannot understand at all. So the communication is the problem. And then the capacity building education need improvement. Basically, we have to we have to check, monitor, evaluate our curricula when we are talking about the university education, because somehow the One Health is not yet really embraced in the curriculum. Socioeconomic is a great challenge in our community, because some of the diseases, for example, anthrax, for example, or rabies, is really related with the socioeconomic thing that is beyond the expertise of the people that is working in the lab, people working in the human side, or people working in the veterinary medicine. And then the other challenge is about the funding and resource. Of course, it is need to be pushed from national or even international, uh, global level, how to tackle down the limitation of this funding and also resources. Workforce capacity, we have a very limited people that is really understand how to work with a One Health approach, because we are not prepared yet. Our education is not really concentrate how to introduce the One Health approach to our students, for example. And then government and leadership, we are really rely on their ability to direct us to the correct direction about the implementation of this One Health approach. And we have also very limited surveillance and monitoring in our case. So how to boost the implementation of the One Health in our countries? I think at least we have to have these 6 concentrate effort. The first is we need to strong governance and leadership at the higher level. We need the direction from our leaders how to implement One Health in every sector. The second thing is the capacity building and training. We need to do capacity building and training to our people to understand how to implement One Health in the field. And then good coordination and collaboration between all sectors and level, because sometimes we have ego-sectoral thing, right? We think that our sector is most important and the other sector is less important. So we are not open mind and we close the discussion. So that why we cannot do the good coordination and collaboration among sectors. Education and awareness of people, it is our job. Professor Frutos mentioned the importance of education also, how we address this One Health, and then introduce to them, and then hopefully they will master enough to implement One Health in the daily life. Strong partnership between sectors, between institutions, between countries, and also between agency. It is important also. And the last thing is financial support. Yeah. So that is the challenges and the how we may boost the One Health approach implementation in our world, of course. And now the second part of my talk is I want to introduce how One Health approach is implemented in our university, Universitas Gadjah Mada, that is located in Yogyakarta, Indonesia. Our university is established in 1949, and it is quite big. With our student bodies is around 39,209 people that is study in our university, and our university consists of at least 18 faculties and 2 schools. So various faculties in our university. We have faculty of medicine, nursing, and public health. We have faculty of veterinary. We have faculty of economic. We have faculty of agriculture. We have faculty of engineering and other faculties that is really consisting from various disciplines. And then the One Health approach implementation in Universitas Gadjah Mada actually has been started very long time ago because our university is actually one of the founder of the Indonesian networking of the One Health actually. And then this One Health approach has been implemented by the faculty, school, research centers, and study programs. We have more than 200 study programs in our university. And then other units like we have hospitals, we have animal hospital, and we have other unit that is might be possible to be one of the unit that is will implement the One Health approach in many aspect. And then just now the university have we call it as One Health Collaborating Center Task Force. It is not the only unit that is working in One Health approach. I mentioned before. One Health approach, and One Health has been already accepted, addressing and implemented in many units under our university, using the value of integrative, collaborative, innovative, and also inter and transdisciplinary. Maybe the One Health Collaborating Centers Task Force can be one of the hub to make sure that all the unit have collaborative to implement the One Health in learning, research, and public service course. And then I want to show you how the acceptance of the One Health in among our students. And last year we have uh, we have a, uh, we have a survey, online survey. There are at least 4 questions that we ask to the students. Well, have you ever heard about One Health? And then it is strange actually because not strange. It is interesting that only 70% of students know about the One Health in health cluster, and less, maybe only 42% in non-health cluster. For example, in Faculty of Social Science, Faculty of Culture, for example, they less understand about One Health approach. And then the second question is that do they involve in the One Health activity? And it's very few, only 10% in health cluster, and then only 3% student that is belong to the non-health cluster. So it is very few only. And then what about their impression about our university? Is there any One Health approach implementation? And only 32%. And even lesser in non-health cluster, only 19%. And then also the same question when they were ask about the One Health approach has been implemented in your unit or not, and only 44% and only 18% agree with that. But actually, when we asking the student about their willingness to discuss and willingness to collaborate among sectors, then their willingness is always almost 100% and 98%. So meaning that actually they are willing to discuss in one multi-sectoral or transdiscipline approach, and they also eager to have collaborate. And what about the perceived skill? Yeah, it is lesser, of course, but still it is quite high, though their experience is very low. When we asking about the discussion transdisciplinary, they saying only 60%, and what about the experience of collaboration, only 60% also. So it is great challenge to our task force and also our faculties, our lecturer to implement One Health approach, because it seems that the student knowledge about One Health is not really good enough, right? And then we learning from that, we have a strategic policy that we need to increase awareness, the importance of One Health among our students, among our lecturer, right? And then we aim also to increasing the number of study programs that include One Health material in their teaching curriculum. And the third is that we need to improve the quality of research using One Health approach. And then the next is improving involvement of lecturers and students in research with One Health approach, and then also increasing the number of community service with One Health approach. This 5 strategy is to answer that the fact that the One Health approach is somehow not really recognized by our students. And then these are the activity in the learning aspect. We do the One Health webinar series. We do the One Health summer course. We also even established the One Health concentration, as one of the concentration is in the Master in Public Health. And we have a Master in Public Health program, and one of the concentration is about One Health. And then we also doing we established the elective module, One Health elective module, that may be offered to the student, from the many faculties. And then also we propose the possibility to have the student mobility among university and our university collaborators in Leipzig and also in Cairo. And then in the research, of course, we are really eager to have intense discussion with and proposal development with the Global Health Consortium, as I mentioned before, with serta, where the Professor Roger Futos work, other university in the overseas and also in national level. And then we do the public service, meaning that we have a One Health podcast. We're doing some promotion using poster competition to raise the awareness level to the One Health. We have also One Health talk show, and we have social media, Instagram and other thing, to introduce the One Health and also to help provide people in our society more the importance of health information, especially using a One Health approach. Yeah, these are the other example where the social media campaign was performed by our task force. And then thank you very much because it is already 21 minutes. Thank you very much, moderator. Good afternoon.
Oke, terima kasih Profesor Triwibawa. Thank you, Professor Triwibawa, for your very informative presentation about Indonesian Global Health Consortium 2023. I think there are so many activities has been done in this consortium, and we hope it will be initiative that will increase in the next upcoming year. And now we move to the next presenter. He is Professor Isam Benis. He's from Mohammed VI University of Science and Health, Casablanca, Morocco. Good morning, Professor Isam.
Good morning.
Thank you for joining us in this webinar.
It's my pleasure.
Professor Isam will present about One Health university programs in Morocco compared to other North African countries.
I don't know if you are seeing my presentation. It works?
Yes, please, Professor Isam. I can see your slides and also can hear your voice.
You see the slide?
Yes, go ahead, Prof.
Okay. Perfect. Thank you so much for your invitation, esteemed colleague and participant. My name is Isam Benis, and I'm from Mohammed VI University of Health and Science. And I am with the pleasure to focus on this critical analysis of the current state of the One Health that you planned during this seminar, international seminar webinar. My acknowledgement goes further to the organizers without exception, and thank you so much for your invitation. What I will say that from human health perspective, approaching One Health is highlighting the intrinsic connection between human well-being, animal health, and environmental integrity. as you see, we know the history of development of curriculum and also the development of all the competency needed for One Health profession, education. And we know that imperative that we move beyond superficial understanding of this meaning of One Health. This is too important to understand that and to go further to understand more what is the best solution to implement One Health principle in practice to address complex health challenge holistically. So we know in North Africa we have the favorable environment because this is a place where we have a lot of burden matching to the One Health principle, from zoonotic diseases to environmental degradation. Despite this, our efforts are often remaining problems start and have to be on this situation. For fragmentation and the scope also, the necessity for a cohesive and integrative One Health approach that transcend traditional boundaries. So we cannot face and control any One Health problem by working just in one country, but we need collaboration to success and to have more successful results. So what is really understood? So it's just a state of the art. We understand the new definition of the One Health. We widely recognize it, the academic and professional cycle during this 5 years. That means after the COVID-19, we understand more this problematic and the new definition of the One Health. However, without true interdisciplinary collaboration and integration, we risk oversampling the concept, and this is the main problem. And if we oversampling the concept, we will fail to achieve this transformative impact of the wanted One Health promise. That's promised. So, what is on link to the curriculum of the competency on the programs? We already have evidence about the development of competency, which is essential to preparing professionals able to address health issues on this concept. So by the intersection between human, animal, and environment, while some university in sub-Saharan for example, they developed already many master programs in One Health. As you see here, Benin, Malawi, Ethiopia, Cameroon, we have already this further examples where masters are already developed. But when we return back to Morocco and North African country, the standardization of curricula and the absence of the ability to produce real workforce interdisciplinary problem solving, it became challenging. Why? And this is why supporting international organizations are there. So even with the support of WHO, the MO, or Afro-WHO, even with the support of the Africa One Health Network or the Africa Centers of CDCs, we are not able to promote more and challenging masters and attractive masters on One Health. I will explain more that. Because, for example, one of the observation that we can have is that in Morocco, the interest of the One Health concept after the COVID-19, it became really understood. but research and institutions are also associated to do more work in One Health concept. But, the growing prominence of this One Health concept is a fact. But the problem is that this enthusiasm often lack the foundation of a structured interdisciplinary framework, leading to efforts that are fragmented and not, well, I can say, not fully aligned with the core principle of the One Health. So, and this is prominent when we see who published and how articles were published and which articles were published from North African authors, for example. The main problem here, when we look for such question with this situation, is the loose definition of the One Health in publication. What is the right to One Health published article to follow this information? A significant challenge we face is the vagueness of the One Health definition in academic publication. And the ambiguity allows a broader spectrum of research to be labeled as One Health, even when it leaks through interdisciplinary integration. Such a loose interpretation diluates the concept of One Health, and it not make possible to establish more precise and operational definition to be cited as success story or to be reproduced as practical application. So we have a lot of community, a lot of association, many university and institute, governmental ministry who promote One Health in Morocco. Many seminars, many conferences, many webinars, but at the real conclusion is that this is what I said, unspoken conclusion, the One Health concept remains in embryonic stage because we don't have the capacity to publish article that is really matching with the new definition of interdisciplinary One Health concept. So what is the other side? For example, in Tunisia, in Algeria, in Egypt, they become also working on One Health for years before, especially on veterinary faculty who amorted this things, and the result that even with this well understood and working on One Health, they don't have real masters on One Health. So as you see here, this is a newest publication in 2024 that mapped the global One Health postgraduate program. And as you see, the problem that we have in Africa, all Africa, just 5 programs, 5 countries who have a master's degree in One Health. One of them is in Morocco, is located on the Veterinary Institute Hassan Dou in Morocco, in Rabat. So the main problem now is that we know the concept, we have a motivated servant society, we do a lot of webinars, seminars, conferences to promote, to understand, and to collaborate or to seek for collaboration, intersectoral collaboration. But the problem is when we arrive to a standardized curriculum, we will not find more than just One Health effective master in Morocco, included for years in Hassan Dou Agronomic and Veterinary Institute. We have, on the other side, many other types of masters when we don't use One Health as the right first name on the master, but we use it as a model or as part of curriculum. And you can see here many other masters existing in different universities in Morocco, different places in Morocco, master of bioresources environment, master in science and technology and environment, master in environmental science, master in environmental science and sustainable development, many, as you see here on the slide. And the problem is that maybe one head is not enough to fill career or to find jobs. This is why the universities or the curricula proposals are not using this unique word of one head as a master title. So, and this is also a question that could ask for Asia or Latin America. Maybe it's not the same case, and maybe the master with one head could be a job finder by itself. If not, I want to discuss more this situation, because it's also with using attractive university certificates like One Head Fund that exists mainly in USA, in UK. We have to face a lot of difficulty to reach audience to participate on such certificates. So the problem is not understanding the One Head concept, it's not to building right curriculum, because there are standards and there are approaches that we can standardize and we can follow. But the problem is the attractiveness of these titles of degrees. It could be problematic. So the hidden problem, I think I succeed to explain the master title value. If we talk about master in one head, is it valuable or not? In which country, in which situation? And this is what we want to work together to change this perception or this stigmatization against the one has any title of university degree. So shall we develop a competitive masters in one head just to say that we have masters in one head? Or shall we invest more on continuing training one head and building more and more possibilities? So this is another question. And I continue with another question. If we don't have continuing training attractiveness on one hand, if we don't have masters on one hand that is also attractiveness, we will not have very good PhD program or students that will follow and develop the most challenging and wanted experience and studies and projects targeting the real definition of one head. So this is another problem from this unhidden spokenness. So let's return back to another problem that could be more understandable from the overview. Is the lacking experts. It could be also a lack of specialized audience on one hand, journals. Or maybe it could be a problem with robust one-head journals. And when you seek, for example, just a quick search in doig.org, you will find that there have just 9 journals with tightly, completely, or partially with one head. But no one has yet the DOIG seal. So it could be another debate, but as you see here, the 9 third journals that have as aim and scope one head. So if we are the community that defends one head perspective, and we want to share one head as a science, we need to focus more on the scope and the aims, and when we should to publish, it should be also reaching targeted, specialized population of experts and researchers, like other disciplines. When you are pharmacist, you look for pharmacist journals. When you are cardiologist, you look for that. So if we are really One Health specialist, One Health expert, One Health researcher or science, we should have to target our effort, our publication on very specialized journals. That, for my experience, it's not easy to debate. So it could be another debate, but I return to the main presentation to talk about curriculum that exists in North Africa and especially in Morocco. And you see that the problem is not the curriculum, but the attractiveness of the curriculum. This is why many masters were introduced before, years before, but it does just stop it because they were not attractive. So the remaining question now is how to create experts in One Health approach if we don't have the possibility to have a program curriculum that is attractive. So I propose steps on 6 steps that could be maybe challenging to implement, but with international collaboration, it could be easy to implement. For the first step is to standardize the continuing training knowledge to get similar attitude and produce more standardized practice by the training. The second is getting more evidence on the real success stories and implemented on this continuing training. The third step will be standardizing the outcome tools of continuing training based on those successful use cases. Then we can reach the multi-university certificate. That means for targeting, for example, science of One Health. So standardizing also the name of the certificate, the name of the master over the world, and sharing the same name. It could be very attractiveness and very attractive. It's like when you say master in public health or master in global health. We need decisions about that. And this is really, for my opinion, is really an urgent decision that should be taken. Then, if we succeed to do that, maybe we will go further a step to talk about inter-university diploma. Then, all after that, when really we will have a lot of people who will have this university diploma, this university certificate, then we can be more attractiveness for starting or implementing real master of science of One Health. So another question is about also what would be interesting as One Health for other specialists like pharmacists, dental doctors, nurse in different specialty, and for example, biomedical engineering. I didn't find a lot of information or program specific or targeting such population of health professionals. And the remaining question is One Health should be or not be included in which university master curriculums. This is another question that could be maybe respondable depending on each country and each university. So I will just affish this public announcement that our university now is opening application for PhD programs, and I am director of these 2 specific targeted titles that reach One Health. So if you know any medical, veterinary, pharmacy doctor who wants to do this specialties PhD program on One Health, is welcome. It's an international open application, and it's currently open at our doctoral study center at the Mohammed VI University of Science and Health in Morocco. So you have the link, but you have also the right to communicate straight with me without any problem. You are welcome. So I will just summarize quickly what I just said. Advancing One Health in North Africa require deliberate and collaborative efforts by addressing these educational gaps, clarifying definition, creating tangible career pathway that could promote more and value more this master of One Health from popular and from the concept itself. It could be an impactful discipline that will arise. We need more journals that publish specifically the right research on One Health, and we should decide quickly about standardized international pathway of education that targets and with the aim to provide more specialized One Health researcher in the near future. Thank you for your attention and engagement and for your invitation. And please do not hesitate to reach me in any collaboration, discussion, or further information. If you have any question, also I am ready to answer. Thank you so much for your attention.
Thank you, Professor Isam from Morocco, for a very informative presentation. I think he is questioning about the degree of One Health Science, yeah? And maybe after this we can discuss. And the participants, please hold your question. One more presenter, and after that we open the question and answer and discussion. The next presenter will be Professor Ira Nurmala from Universitas Airlangga, Surabaya, Indonesia. She will be presenting the sociology, health promotion, and One Health. Professor Nurmala, the slide is yours, please. Is it recording? Okay.
My name is Ira Nurmala. I'm from Health Promotion and Behavioral Sciences, Faculty of Public Health, Universitas Airlangga. And today I'm going to present some of the information that I have in regards to the sociology, health promotion, and One Health. Okay, this is a brief profile of mine. Please feel free to check the links, and if you like, you can also cite some of the work that we have done, and maybe it can also beneficial for your future research. So today's outline, in the next 20 minutes, I would like to share about sociology and public health, health promotion, and One Health. First, we're going to talk about sociology and public health. Return to the WHO definition of health, that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease of infirmity. So it means the health of the population, the vitality of the population, are dependent on the ability of make successful adaptation with the environment, so individual will survive. Individual ability to adapt depends on the capacities and skills, and also the psychological orientation. To the large extent, the individual construct their own environment, and we can have all the models and norms that the culture and society provide for them. Much of the content of sociology related to the concerns of people's adaptation to the changing environment, so the field has important implications for the public health practice. It is, however, very important to note that the perspective of sociology and public health is different. While public health is an applied endeavor that imposes a normative criteria and then attempts to implement, the sociologist's major concern is with understanding social phenomena that is independently influencing people's behavior in such understanding. It is widely appreciated that the cultural and social variation play a role in a manner of speaking, because people define their own health program, they participate in the health maintenance program, and they utilize the medical and other health services. For example, there is a considerable evidence that socioeconomic factors are related to the knowledge about disease, the use of medical and dental services, acceptance of preventive health services, purchase of voluntary health insurance, and also when decided whether they are going to use the medical treatment or whether they're gonna use the remedies which is from the folks-made remedies or from the self-medication. And individual skill and communication and effectiveness depending on the preparatory institution of the community provide in dealing with problems as individual and as a member of group. Individual motivation and direction of interest will also depend on the incentive of the community provides and promotes for the promotion of health. Individual psychological activities and strengths also influenced by the human resources and the social support, and also how the environment can provide for all of this. Although individual can do a great deal to promote their own health, they can only do it on the narrow limits. In the larger context, life and health are really substantially dependent on the how the community around them decide on what to do, and also by the social forces that sometimes outside the individual owns control. Now, when we're talking about sociology, sociology is actually the study of society. It may be defined as a social science, of course, but it's also defined by a lot of things. For example, some experts define sociology as the structure and function of society or system, the nature and complexity and the contents of human social behavior, the fundamentals of human social life, the interaction of human beings with their external environment, the indispensability of the social interaction for human development, and sometimes people just are looking at how the world, how the social world affect us, and etc. So sociology actually defined also by a team of experts in 2000 as a social studies, which is process and patterns of human, individual, and group interaction, the form of organization on the social group, the relationship among them, and the group influence on individual behavior and vice versa. Also, a study about the interaction between one social group and the other. So, sociology is the scientific study of society, and this is means that we study the relationship between people, but in a group context. It is interested how sociology looking at human being, because we cannot be isolated with each other, so we have to be interact with each other, and there are some kind of social pattern of interaction, and this is also involving the law and principle that govern this social relationship and interaction, and also it is also influence the social world of the individual and vice versa. Sorenka states that sociology also is a debunking science, that on the level of reality, it is presented in official interpretation of society and people's common sense in explanation of their social world. So sociologists are interested in understanding what makes sense, and we should not make a value judgment of what the people behavior, because people behave based on what they believe, based on their society, based on the norms that are exist in the society. So, in terms of relation of public health, I would like to also remind us that public health itself is a science of an art of preventing disease, prolonging life, and promoting health through the organized effort and informed choices of societies, organization, public and private communities, and individual. So public health is a science, but also it is art. Art plays a role in looking at the society, how the social interact with each other. So reminded of Winslow definition of public health, we do need sociology in understanding human behavior, especially to maintain their health. Public health also means that we have to look at the preventive and promotive effort to ensure that society is always in optimum health through a multi-perspective approach. It means that we need a lot of background in the public health. We come from a variety of background and we work in a variety of setting for the common goals of promoting population health. So, in doing our responsibility, we obliged to conduct health education to increase awareness of the people that leads to increasing attitude and behavior toward health. The core function of public health, including assessment, policy, and assurance. Assessment means we are systematically collected, analyzed, and make available information on health communities. Policy means we promote the use of scientific knowledge based in policy and decision making. Assurance means we are ensure provision to service for people in needs. And this is the 10 essential of public health services, starting from the assessment, policy development, and assurance. So we monitor health, we diagnose, and during the investigation, we inform, educate, empower, mobilize, and develop policy, enforce law, and then we provide links to medical care, and we assure a competent workforce, we evaluate, we research in a public health field. So we come to the next section, which is the health promotion. So health promotion aims to enable people so they can have a control over their own health. And there's a definition by the World Health Organization. So it is cover a wide range of social and environmental intervention that is designed to benefit and protect individual people's health and quality of life by addressing preventing the root cause of ill and not just focusing on treatment and cure. So it means health promotion also develop the individual, group, institution, community, and they have systemic strategies to improve the knowledge, attitude, and skill behavior for this individual, group, and institutional, also community. The goal of health promotion is to determine whether the health behavior of individual and communities. Also, we determine the living and working condition of these people and how they influence these people's health. So model of health promotion, there are many sources, but I would like to share with you the one that from Donny. So the models include the prevention, the health education, the health protection. And it means we have to conduct preventive services, preventive health education, preventive health protection. We have to conduct health education for preventive health protection. We have to do a positive health education, positive health protection, and also we make sure that health education aim at a positive health protection. So this is all related to each other. And according to the Ottawa Charter, if you want people to be healthy, then there are some prerequisites for health. And this is in the Ottawa Charter. It means that if we want people to be healthy, we need to create a condition and resources that is sustainable for people. And this include peace, shelter, education, food, income, a stable ecosystem, sustainable resources, and also social justice and equity. So without this, according to Ottawa Charter, people cannot be in the optimum health. The concept of health promotion, therefore, is socio-environmental, which is structural. It means that there are connectedness between family, friends, community, and they should be able to have a control and ability to do things and that have meaning for their health in their community, and there are a social structure supporting human development. It means also there are some psychosocial risk factor and socio-environmental risk factor can include poverty, income gap, isolation, powerlessness, pollution and stressful environment, hazardous living, and also working condition that needs to be tackled in the everyday life. there are changing. We're talking about the public health, and now we're talking about health promotion. So in the public health, we did a lot of things. Start from the environment, and then the disease control, and there are some health education and immunization, and also there's disease control that we have conducted. But in 1960 to 2000, we also concerned about the social determinant, we concerned about the environment. So this is all for improving the health of individual and society. This is the broad concept of health promotion. There are a medical, which is a traditional concept, and then there is a lifestyle concept, which is behavioral, and also socio-environmental and or structural. So these approaches lead to different definition of problem, different strategies, different target group, and different people, and they're all responsible for the activities of promoting health. So in terms of One Health, so when we talk about the public health, the health promotion, we understand that health is not only the physical health, but also mental, social, and others. So this is involved also the spiritual, vocational, socio-economic. So talking about health is talking about all of these elements, components. So in One Health, we also believe that there are relation between host, agent, and environment. So this is why we tackle health, not only to improve the health of the host, but also to make sure we understand the agent of creating the problem. And also we have to make sure the environment is conducive for healthy people. So it helps in identifying risk factor, and it helps in describing causes of illness. The component of this model means we have to look at the agent, look at the host, and look at the environment, because they are all related in influencing people's health. H.L. Bloom also mentioned this in the model. It says that there are psychosocial health, which is well-being of people, the environment, the healthcare services, the hereditary, and also the behavior of people that influencing their health. So One Health is an integrated, unifying approach to balance the optimize the health of people, the animals, and the environment. And it involves public health, veterinary, public health, and environmental sectors. So according to one of the articles that was published in 2024, it also mentioned that the One Health perspective has been adopted by quadripartite. So there is an alliance of 4 global organization, and I think this is the best way to describe One Health, because now everybody has the responsibility to making sure that the health of the people, the animal, the environments are being attention and being protected. And this is also mentioned in the article that if we want to have a healthy people, we have to make sure the animal also healthy and the ecosystem also healthy. And this can create healthy lives, healthy people, healthy spirit, and healthy ecosystem. So I would like to introduce you to one of the projects that are currently conducted by a team of Universitas Airlangga from FIKIA, Faculty of Health, Medicine, and Life Science in Banyuwangi, and the project called New BRIN. So New BRIN is a community services, and it is a combination of sea turtle, or we call it penyu in Bahasa Indonesia, and also eco BRIN. So hence the name of the project is New BRIN. So the program is focused on empowering the local community, and it is at Pulau Santen. Pulau Santen is one of the, right now is a lot of tourists, domestic tourists also come to this Pulau Santen in Banyuwangi, and we promote, the team promote the sea turtle conservation and also the effective waste management practices. And through New BRIN, the team encourage the community awareness of environmental preservation by the conservation of sea turtle in the coastal area, and also they are being taught of to process the waste with the EcoBRIN as the method, so they can reuse, recycle, and especially reducing plastic waste that can influence the health of the environment. So the new BRIN aims to make a positive impact on the marine and coastal ecosystem, also empowering the community to protect their environment. And I'm lucky that I actually able to visit the site. We also released the penyu in the ocean, and the team said that the penyu will return in 20 years to actually have the eggs planted in the sand. So if this beach is protected, the penyu is protected, then the people also will protect them and protect the environment where penyu can live healthy, and the environment is healthy. So hopefully the people will also healthy also. So in summary, the health promotion approach, or we call it positive health or asset-based approach, is a powerful coagulant for inter and interdisciplinary and transdisciplinary thinking, and it is time to re-emphasize and reinvigorate the notion that health is not merely the absence of disease or infirmity, but also a systematically inherent aspiration of the entire planet in all its wondrous diversity. With the renewed emphasis on One Health in the quadripartite plan of action, is also we can learn that there are opportunity to invest in the health of nature, ecology, spirit, balance, and the benefit of all, including that class of humanity. A One Health promotion perspective will generate stability, harmony, and resilience, and it would make our world a better one. Okay. So thank you, and I would love to work with you all in One Health, because I do believe in maintaining the health of the environment, the animals. It also meaning that we have control of our own health as the principle of public health and health promotion, and we can work towards the One Health together. So in dealing with any obstacle that we have in our activities, I would like to share my own personal jargon that I keep sharing with everyone that I know, that in doing One Health and in doing any activity that we like, so we have to keep moving forward with a smile and positive attitude. So thank you, and I apologize I won't be able to attend this webinar because there's another engagement that I have to attend to, but I'm here and you have my personal link, so I would love to wait for our correspondents to talk about anything about the health of everything in a term of health promotion and public health. So thank you everyone, and salam sehat for all of us. Thank you. Bye.
Yeah, thank you, Professor Ira Nurmala, for your presentation. And I'm sorry if I said before that we are going to question and answer, but since Ms. Jena Dawson Faber cannot attend this webinar, she is replaced by Dr. Ross McEwing. Good afternoon, Dr. Ross. Yeah, she is from Safe Project Officer, United Nations Office on Drugs and Crime, UNODC. In Hanoi, Vietnam. She will presenting reducing the risk of the next pandemics and addressing illegal wildlife trade, introducing to the SAFE project. Dr. Ross, please, the screen is yours.
Terima kasih banyak. Selamat siang. Hope you can hear me all well. And you can see my slides and presentations on the screen, yes?
Yes, sir, please.
Perfect. Thank you very much. So apologies. I've literally stepped in at the last minute to give this presentation. My colleague Jenna was taken unwell about an hour ago. So we're all new to these slides. So I hope you can indulge me a little bit as I try and talk through the project. This is a slight aside from the previous presentations, which were very interesting, fascinating for me to hear. This is a much more ground up project, and hopefully it will alert some of you and engage some of you with your academic mindset as to some of the issues that we're facing. So as introduced, I'm Ross McEwing. I'm actually based in Bangkok, Thailand. Jenna, my colleague, is in Hanoi. And I work for UNODC. And UNODC is the United Nations Office on Drugs and Crime. So we know One Health is broad, but perhaps you didn't understand that drugs and crime are somehow involved as well. Well, within the drugs and crime team, we have an environment team, and we focus on the illegal trade in wildlife. So this is the connectivity here to One Health, as we started a project funded by the European Union, FPI. And what we're really looking at in this project is the commercial wildlife trade in Southeast Asia, and this overlap with the illegal wildlife trade, because we believe that that compounds the threat of potential zoonotic disease. So this is the origin of this project. The UNODC lead it, but we work with our colleagues at ICTAD, at FAO, and with the legal department at UNEP. So what is the SAFE project? Well, this project started in 2021, due to complete in 2024, but has been extended to 2025. So the aim is to reduce the zoonotic disease risk, the potential for spillover from wildlife. We all understand now the significance of potential disease spillovers from wildlife to humans. We've lived through the consequences of that. And as I said before, we believe that there's this nexus between the illegal wildlife trade and spillover really compounds this threat. So it's really also starting a dialogue between Asia, between the United Nations and between the European Union, who are really interested in this subject and have their own concerns around it as well. So it's to improve dialogue and improve coordinations and discussions, really around biosafety standards in the commercial wildlife sector and policy recommendations. What's missing? What do we need to improve? What lessons have been learned? So we're certainly working towards a One Health approach, but it was fascinating for me listening to some of the presentations. I've been to lots of One Health meetings, and this project in particular is a bottom-up approach. And sometimes I found with a lot of the One Health approaches is that there's a huge disconnect between what happens on the ground and what is being discussed at the policy level. And really this project is trying to bridge that, and a lot more projects will need to come along to bridge that gap, because it's very important that people know what's happening on the ground, because it's very concerning. And just to say what the project is not, so it's not a COVID-19 origins project. This was very important for us to stress. The project certainly began as a consequence of COVID-19, but we're not looking to apportion any blame or looking for where the origins came from. The science is leading us in a certain direction. I think we're all probably going in that direction. So we understand that. We're not collecting any samples for laboratories to analyze. That's not part of this project. Importantly, we're working with 3 countries in 1 state. So we're working with Vietnam, we're working with Thailand, we're working with the state of Sabah in Malaysia, and we're working with Lao PDR. So the information that we generate from this project, we're giving only to the government recipients. So we're not disseminating huge amounts of data. We're trying to inform the government, give them some information which they can then take to their One Health partnerships or action groups. And importantly, from a UN perspective, is we're not pushing any preconceived ideas. It's not our aim to close down wildlife facilities. It's not our aim to have people stop eating wild meat, because we know there are food security issues there. So we have no preconceived ideas about where the data will take us. So what is the project? As I said before, the 3 countries and the Sabah state where we're working, well, we didn't really know how to address this issue. We know there's a huge amount of wildlife that's traded legally and illegally in Southeast Asia and in the countries where we were working. And what we wanted to do was find out really what we didn't know. So we created a system where we wanted to go to facilities, commercial facilities that housed wildlife, that were breeding wildlife, to try and understand how they operated. And this is a bit of a challenge sometimes because a lot of the time those facilities are operating illegally in one way or another. So during the course of the project and across those 4 countries, we visited about 160 different wildlife facilities, commercial facilities. And we developed a risk assessment framework, which was just a questionnaire. And we went to those facilities, often with their government counterparts, sometimes without. And we sat down with the owner of the facilities and discussed how they operate their facilities. And we had an assessment, so we walked through, we visually saw what was going on in those facilities. And we tried to narrow down to 6 key areas that were really important to us that we had assessed through some of our scientific groups as to where the highest risk was going to be in the commercial wildlife sector. And for us, that's captive breeding. A lot of the times this is called wildlife farming, but it's certainly captive breeding of wildlife for consumption or for the pet trade. So this happens all over Southeast Asia. There are, of course, traditional markets, and often wild animals are for sale within those markets, even though guidelines suggest they shouldn't be. There are still lots of wild animals for sale in traditional markets. Restaurants that are selling wildlife were an interest to us. And then the biomedical trade is really interesting to us. The sale or the trade in macaque. There's a huge demand for macaques. So an individual macaque going into the biomedical trade is probably worth upwards to about $10,000. So when you have a high price on one single animal, then there's a huge amounts of illegal trade associated with that as well. And those animals were making their way to lots of different markets globally. So we were very interested to know how people were farming macaques for the biomedical trade. And then zoos. Zoos mean different things to different people. And in Southeast Asia, it's a very broad term. So for lots of people, zoos, a facility that you can visit and see animals. In other countries, it's just a facility that has animals, not necessarily open to the public. And perhaps sells animals. So it's a very loose term. So we wanted to visit as many facilities as we could. And then this increasing trend towards animal encounters. For those who live in Thailand, you'll see this a lot. Every time you go to a mall, the mall will be full of a wildlife display. There will be wildlife on show, and you can go and interact with the wildlife. You can feed the wildlife. You can have your photograph taken for money. So this huge issue for us is looking at the transmission of potential disease. Where are the spillover risks and where are the transmission risks as well? And I mentioned before that we had created a risk assessment framework. This is our questionnaire. And this ended up being about 116 questions that we were asking people. We thought, of course, it's way too many questions. And those are all open questions. So we went to a facility and we started asking those open questions. And luckily, the people who are breeding wildlife and commercially involved with wildlife were very open, sometimes too open about how they were operating. But it was a really fascinating process. So we asked questions on the socioeconomic aspects of their business, how many staff they had, what kind of healthcare they offered, what kind of awareness they had on potential for zoonotic disease. We looked at the trade chain, where they were sourcing animals from, where they were selling their animals to, how they were moving them, how they were moving those wildlife animals to product, how they monitored the health and condition of their animals, whether they were complying with registration and licenses, what types of species did they have on site, and that included not just wildlife species, but also agricultural species as well, farmyard species, dogs and cats. That overlap is really important. Whether they were aware of risks, aware of how they should be operating, what qualifications they had to manage these types of facilities, how they dispose of their waste, how they manage waste, including dead animals and carcasses and bio-waste, how they could trace the animals, which was really important as well. So we really looked at a huge range, and people were very honest with us in response to this questionnaire across all 4 of those regions. One of the other things we did is we undertook a review in all 4 of the different regions of their legal and policy, and our colleagues at UNEP did this. So they looked at all the laws associated with wildlife and wildlife trade, and then moving into breeding and the selling of animals and the commercialization of animals. So we wanted to look at those laws and make sure that they were sufficient, and where they weren't sufficient, where we should target interventions in terms of changing regulations or introducing better standards. We also, within this project, had national dialogues. This is really important from a One Health perspective. We brought together agencies, and the agencies we were working with tended to be wildlife departments, livestock departments, and sometimes other commercial departments as well within a country. So we brought those people together, including the disease control people, and we were very open about what our findings were, what the issues were, and how people had to really grasp the issues, because for us they were very, very serious. And we have now country-specific workshops, and I'll discuss maybe some of those a little bit later, but looking at the private sector. So we wanted to figure out from the private sector what their views were about government licensing and registration, about standards, about what they wanted in terms of guidance from government about how to operate their businesses. But also things about disease reporting. We had many captive breeders tell us that in some cases they had a total stock die-off. All the stock they had died off very, very quickly from disease coming into their facility. But they had never reported this. There was no mechanism for reporting disease outbreaks within those facilities. And this is really important. This is something we're now talking about and trying to discuss and develop SOPs within countries, or just refresh SOPs within countries to make sure there is this reporting element for disease. And inter-regional dialogues, that's really important for us as well. We have within our group, we have a scientific advisory committee, we have international experts. We're bringing this information to people and asking their advice. And this is really also at the ASEAN level. We want to bring in as many people as possible, as many technical experts, and have this dialogue. We focused on 4 countries, and we really wanted them to be pilot countries. It wasn't particularly we were being overly critical of those countries, because we believe a lot of the issues that we've observed, we would observe across all of the countries in Southeast Asia, if not globally as well. When you have an assessment like this and you go to any country, you will of course find issues that could be resolved or improved. Where are we now with the project? Well, we're producing our country reports. So we have a country reports for all 4 or for 3 countries in the state of Sabah. And as I said before, these are readable summaries effectively of the work that we've done. We also provide the government counterparts, the beneficiaries, with the longer reports and our legal and policy reviews as well. So we're trying to arm the countries with as much information as we can about this particular One Health issue, which is the wildlife trade, the commercialization of wildlife, because we believe it to be important. Coming up, I mentioned before, the public-private sector dialogues. We need to hear from everyone, all the stakeholders. We may find some of the wildlife trade to be ethically challenging, but that doesn't matter. As long as it's legal and it's sustainable, then we should encourage dialogue and how we should improve those practices. Disease reporting, I mentioned before, is absent from wildlife farms and a lot of those types of facilities, and we need to make sure people feel empowered and not threatened to report disease. Licensing and registration was one of our biggest issues. I'll maybe mention a little bit after this. And we're also talking to the law enforcement agencies. This is what UNODC does best. We have seen elements of organized crime in the movement of animals across countries, so across Southeast Asia. So we know animals, for example, will make their way from the wild in Indonesia to go through Thailand, to go through Laos, to go through Cambodia, to go through Vietnam. And that's all organized, and it's an illegal movement of wild animals across borders. And we consider that to be a very serious risk. And also something which is really important to us is about frontline enforcement officers. They are forgotten about in terms of PPE or handling wildlife. They don't get that training. They don't get access to this kind of equipment. So a lot of our training has been looking at what's a workable way for those people to have access to PPE. Not the hazmat suits. Of course, we have to recommend the hazmat suits and all the protective gear, but the reality is those frontline officers don't get access to that. So it's looking at the major transmission routes of disease and making sure they have adequate PPE that they have access to and can reuse if they have to. That's really important to us as well. And what I would just do just before I finish after this slide, where the project has gone, especially with FAO and with UNEP, is trying to pull together this discussion paper, which we want to present to ASEAN. This is really important. As I said before, we're not being overly critical of the 4 countries where we were working, but we think there's lessons to be learned, and we think those lessons are applicable across the ASEAN community and likely globally as well. So we've produced this discussion paper, which we're presenting at our meeting in December. And this will really summarize the main findings that we want action. It's effectively a call to action for ASEAN to really take this issue seriously. If we're worried about the potential for spillover and disease and the risks associated with that, then this is a really hidden element. This wildlife trade really needs to be addressed. It's really important. And just to highlight some of the main results that we saw from the work that we undertook across all 4 countries, and that's really a lack of oversight at the government level. This is quite important because wildlife falls between the mandates of different organizations. So when we're talking about wildlife or farming of wildlife, then we would assume maybe perhaps it's the national parks or the conservation agencies that have a mandate here. Or is it the livestock department, because a lot of the times those animals are being bred for consumption. But in actual fact, it kind of falls between the mandates of lots of different organizations. And what we found was there was no oversight. And most of the time, the government did not know where those farms were, where those wildlife farms were. There was no register of them. They weren't licensing. The licensing was very complicated. So we're very sympathetic to people who were farming in that it was very difficult for them to get the right licenses or to get the information they needed on how to license themselves properly. In some cases, a wildlife farm would need 9 different licenses to operate legally. And that's why they're all operating illegally. Not because, so it's illegal with a small I. It's not that they're out to operate illegally and to make huge amounts of money, but they just don't have the knowledge and are therefore not operating in a way that we would suspect to be safe. And this is really important. If a government knows of those facilities, it can provide guidance and recommendations. If it doesn't know those facilities, it just doesn't know the scale of this. And the scale is hundreds of thousands of animals moving across borders illegally. So that's oversight and licensing. The other major issue that we saw is there's a huge amount of wild sourcing of animals going into the wildlife farming market. So animals are taken from the wild, sometimes in other countries. For example, a lot of the time animals were coming from Myanmar, coming into Thailand, coming into Laos. So they're brought in from the wild. Animals like civets, which we know to be high-risk species, coming from the wild, coming then into some captive bred operation, but coming into that without any quarantine. None of the facilities that we had ever visited had any comprehension or knowledge about quarantine. In fact, none of the facilities we visited ever had any veterinary support. So they were self-administering antibiotics on a regular basis. I know that should alert some of you to the issues here. So it's an underground, but often legitimate and potentially sustainable business, but it just has no oversight. And this is why for us, it's a real worry that something has to happen here in order to address these issues. Animals are then moved. And a lot of the time, the end market is Vietnam for consumption. So those animals are moved without any permits across borders. They're moved in very unhygienic ways, very crammed ways, really stressful ways across borders as well. So all these kind of amplification effects for the potential of viruses is really worrying for us. And that movement across different countries is the illegal trade. And this is something that we are very keen to try and address. So we're not against the movement of animals for consumption if it's sustainable and if it's legal. But the main observations from the work that we were looking at is that's not the current situation. So just finally, we have our meeting coming up on the 3rd and 4th, and this is really a dialogue. We're trying to bring together lots of people from the EU, the specialists from the EU, to work with some of our ASEAN counterparts. So from the ASEAN expert groups. So we're bringing as many people as we can together to talk about some of our findings, to share experiences, to talk about our discussion papers, and really to have a bit of a roadmap of recommendations and actions moving forward. We believe that this is a really serious issue, and just given the history of what's happened in the last 5 or so years, this needs much more attention. And biosurveillance and preventing the next pandemic, those are all really nice buzzwords, but on the ground, we believe there's a disconnect between a lack of enforcement officers, a lack of inspection officers working at this level, and then what's being discussed at the policy level. So we're really kind of pushing that agenda moving forward. But with that, as I said, thank you very much for your time. And Jenna Dawson-Faber, who was supposed to be presenting today, is probably a good first point of contact if you want to discuss any of the aspects of what I've discussed today. But thank you very much for your attention, and it's a really fascinating meeting, and I look forward to the rest of the presentations. Thank you very much. Terima kasih banyak.
Terima kasih. Thank you very much, Dr. Ross, for your very informative presentation. And I think after the 6 presenters, we can discuss, even there is a very limited time. Yeah? I can see in the question and answer in the chat, there is one question for Dr. Professor Triwibawa. Is Indohun is a part of Indonesian Global Health Consortium or One Health Collaborating Center Task Force? Could you please respond for this question, Dr. Triwibawa? Oh, he left. But he is still here, still in Zoom. Okay, ladies and gentlemen, if you have a question, please raise hand or write in the chat room. And please state for whom the question is. Yeah. Is there any question for the participant? Oh, raise hand. We see. But I cannot see from this screen. Widodo. We see. Yeah, please, the person who raised hand, just open your mic and yeah. Who is raising hand? Mas? Siapa? Widodo. Pak Widodo, please open your mic and you can answer or comment. You can ask or comment, I mean. Oh ya, Widodo. Halo Pak Widodo. Bapak mendengar? Do you hear my voice? Another one. Yeah, we see here Pak Sudarat. Oh no, Sudarat is from maybe from Thailand. Please, Mr. Sudarat.
Hi, you want me to raise the question? Because actually I already tied it in for Dr. Let's see. I already tied it in a question and answer question chat box. I'm okay. Do you hear?
Professor Triwibawa, do you hear my voice? Yeah, I don't know. Maybe he's taking a time for pray maybe, and we will ask him after this. And I think this webinar will continue till 7:30. Yeah. So in the meantime, just wait for the answer or the response from Professor Triwibawa. And due to the limited time, I think it's now to break. For break. Yeah, we still have 6 speakers. We offer you to break for 10 minutes. Is it enough? 10 minutes. So we just delay for 10 minutes. Is it possible? Yeah. Yeah. Pak Debri, please give the access for Dr. Padet, Professor Padet, and Dr. Xuping from China to be a panelist. Ladies and gentlemen, we break for 10 minutes and we'll back at 3:30 Jakarta time.
Use the latest one, not that one. That one is not good. Use the latest one. She put it, Kimberly put it on the chat earlier.
That in the Zoom or where?
In the Zoom chat. Yeah.
Yeah, I'll be waiting. Where's it?
Here's a good one.
Yeah. So the time is not delay. Because it is same.
And for that, we need to invite him as a panelist.
I think
And Shopping as well.
I think
They are
he has been
panelists,
invited.
They are spectators.
Test. Good afternoon, everyone. So we continue our webinar in this second part of the first session today. And we have 5 speakers forward. And Debri, have you give Dr. Professor Padet as a panelist?
Padet already in room, Pak Mugi.
Okay, thank you.
Okay.
Okay, let's start this session. Our next presenter is Professor Padet Siriasetin. He's from Chulalongkorn University, Bangkok, Thailand, and he will present the integrating One Health approach to control leishmaniasis in Thailand, factor, human and animal health perspectives. Good afternoon, Professor Padet. Do you hear my voice? I think you still mute your Zoom. Yes. Please, the time and the screen is yours. The time is 20 minutes. Professor Padet, please share your presentation. Yes, I can see the presentation, but I cannot hear your voice. Please unmute.
Do you hear me now? Yeah.
Okay.
Okay. Sorry. So thank you for the organizing committee to give me the opportunity to present my work today. Can you see the slide? Okay. I will present about the leishmaniasis in Thailand and how we investigate the disease transmission in Thailand and how we use the One Health approach for controlling the diseases. Leishmaniasis is a disease that caused by a parasite that we call Haemophilus. It infects both human, animals, and insect vectors. You can see from the slide that leishmania is distributed in the subtropic and tropics areas like Thailand and also some American countries and Middle East. Is transmitted mainly by female sandfly. The clinical spectrum of leishmaniasis can present with cutaneous leishmaniasis, mucocutaneous, and visceral leishmaniasis. In Thailand, we have two categories of leishmaniasis. It can call imported leishmaniasis that the patient infected outside the country, and we also have autochthonous or indigenous leishmaniasis. That is mean the patient never go out from Thailand and then they got infected. For the imported case, we have the case of leishmaniasis imported every year. For example, in 2018, we have about 100 students from the agricultural school from the northeastern of Thailand went to Israel for the field practice for 1 year. When they returned to Thailand, 10 of them presented with cutaneous leishmaniasis, and 30 of them were positive by PCR from the clinical samples. This just show you that one case that present with cutaneous leishmaniasis, and when we investigate, we found that it's caused by leishmania major that epidemic in the Israel. So we treat them with itaconazole for 6 weeks. You can see the results of the treatment that is healed, but still have some lesions left after treatment. So for the autochthonous or indigenous leishmaniasis in Thailand, is reported increasing every year. The main etiologic agents of the leishmaniasis in Thailand is belong to the new subgenus we call Mundinia, composed of 2 species in Thailand. We call it Leishmania martiniquensis and Leishmania orientalis. Actually, in this subgenus composed of 5 species, the yellow one in the slide, you can see that it is Leishmania macropodum that infect kangaroo in Australia. The green one is Leishmania martiniquensis, not only found in Thailand but is worldwide distribution. It can found in Europe and Americas. The blue one is Leishmania elegii, found in South America, that can infect in the animals as well. And the red one is we call Leishmania strain that found in Africa. And the orange one, that the only species found in Thailand we call Leishmania orientalis, never found outside Thailand. So in Thailand, we found mainly 2 species for autochthonous leishmaniasis, is Leishmania martiniquensis and Leishmania orientalis. This picture shows you that the patient infected with Leishmania martiniquensis is develop a disseminated cutaneous lesion. We can isolate the parasite from the clinical sample of the patients, and after the treatment with amphotericin B, the patient cures. However, not only in Thailand, we also found a case from Myanmar that he has a disseminated leishmaniasis and he fly from Yangon to Bangkok, and we diagnosed him as a disseminated leishmaniasis. This is the patient who got the systemic steroid treatment, and then after we diagnose him as a leishmaniasis and treatment, he cure and can return back to Myanmar. That's about the human case, but how about the insect? The leishmania is as I mentioned, is infect both human, animal, and insect vector. Normally we know that the sandfly is transmit leishmania. However, in recent work from our group, we found that another insect, we call it biting midges culicoides, can be a vector for leishmaniasis in Thailand. So when sandfly take a bad meal, you can see that the parasite that develop in the midgut of the insect. And if you want to incriminate the vector, you need to show that the parasite develop at the internal organ of the insect we call stomoidal valve. Our work for insect incrimination, we will correct sandfly and biting midges, and we dissect them, and we will detect the parasite in the midgut of the insect. This is the our work in the lab, that we dissect insect, we extract DNA, we can some of the midguard we will culture for the parasite. This show the method how we collect sandfly in the field, allow the patient home. We install the light tap during the night time because the sandfly and chilicoides will come during the night time. And then we collect sandfly or biting midget and dissect them under the microscope. And we looking for the parasite in the midgut. We found that allow the patient home, we collect both insects and also animals. We found that black rat might be the reservoir host for the Leishmania in Thailand. And we also found that the positive of the sandfly sample, especially in the genus Sergentomyia, that positive for the Leishmania parasite DNA. We detect several areas of the Leishmania endemic in Thailand, and we found that Leishmania martiniquensis was detected in Sergentomyia kawi. This is another genus of the sandfly that we found mostly in Thailand. And we also found that Phlebotomus sandfly and Gassomyia also may be the potential vector for leishmaniasis in Thailand as well. However, as I mentioned earlier, that the biting midges may be the potential vector of the leishmaniasis in Thailand too. On the left side, the picture on the left side is sandfly. Yeah, feed on bud. On the right side of figure B is the biting midges that during it feed on bud. Why biting midges suspected to be a potential vector? As I mentioned that Leishmania macropodum in Australia, it infects kangaroo. They have a report that the biting midges was found Leishmania macropodum in midgut of the chilicoides. So this Leishmania macropodum also in the same genus, subgenus as parasite found in Thailand too. So in 2015, a group from Prague that they infect biting midges with Leishmania electii, also the same subgenus as Leishmania found in Thailand. The parasite can develop in the stomatal valve of the biting midget, and then when they allow the biting midges to bite guinea pigs also develop lesion of leishmaniasis at the ears. So I and this group from Czech Republic working together using the Leishmania martiniquensis and orientalis, both species I mentioned that is found in Thailand, to infect biting midges. And then we see the parasite development in the midgut of the biting midges. And we found that the parasite can develop in the stomatal valves of the biting midges. So when the biting midges feed upon meal, this parasite will release into another host. And when we survey the area that patient develop leishmaniasis, we collect biting midges and we detect the parasite by PCR. We found that some of the biting midges positive for leishmania DNA in this sample. We just reported a few years ago. So that we interested to explore the biting midges. It might be another vector for the leishmaniasis in Thailand. So this picture already show you, and I remind you again that we found Leishmania martiniquensis and Leishmania orientalis in Thailand. So it belong to the same subgenus like LHI, Canastem, Macropodum. In August this year, we went to the patient homes in southern Thailand. We collect biting midges around the patient home. We sorting the insect and dissecting the insect. And we screen the parasite development in the midgut of the biting midges. And we try to isolate them if it's positive. This is a flow work that when we collect the biting midges, we sorting it and then we dissecting under the microscope. And then we just look for the parasite in the stomatal valve of the biting midges under microscope. If positive, we use the mobile foam hose that we can take it into the field and try to isolate them. So I will show you the video that we found in the field. You can see here is the stomatal valve. The movement, because the parasite is Flagella protozoa, so you can see the movement here. This is suspected to be a Leishmania parasite. This move here, and here is a Namarad parasite that we found in the midgut of the Culicordis. This is also the parasite that have flagella here. So from our flow work, we can isolate the parasite from the midgut of the biting midges. But to confirm that biting midges is the vector for the leishmaniasis in Thailand, we need to show that it feed on both human and animals. We suspected that some apart from rat, it should be cow and dog should be the reservoirs for leishmaniasis. So we take the biting midges into the lab. We use the multiplex PCR for mammalian and avian to detect the blood meal, because if the insect take the blood meal in the midgut or in the abdominal part of the insect should contain DNA of the mammals or other animals. So
1 minute.
Sorry.
More, please.
So now we can show that some species of Culicoides feed on human and animal. We also use nanopore technique to identify blood meal in the insect. So we found that some insect species as you see in the picture, that it feed on human and also some feed on animal as well. So from the data we investigate, we found that Leishmania martinipensis and Leishmania orientalis are experimentally capable of developing in the midgut of culicoides. The field study found that Leishmania parasite colonizing midgut and stomatal valve of biting midgets. Blood meal analysis show a broad range of hosts, including human, that satisfying Kelly criteria for vector incrimination. That it means that it supports that culicoides may be the responsible for Leishmania transmission in Thailand. So, because Leishmaniasis in Thailand is quite new, so we still lack of some information. So we need to fill in the gaps that we don't have information before, like insect vector that I mentioned, and then reservoir host. We know the case of human, but if we can fill in of these gaps, we can use the One Health approach or One Health concept to control the Leishmaniasis in Thailand effectively. This is a flow that we would like to use the One Health concept to control Leishmaniasis in Thailand in the future. I think this is all of my presentation. Thank you very much.
Thank you very much, Professor Padet, for your presentation. I think we know that the Leishmaniasis is one of the vector-borne disease that we should aware, especially for the country like Indonesia or Thailand, which is agricultural countries. And the next presenter is Dr. Xiuping Chen. Are you here, Dr. Xiuping?
Yes, I'm here.
It's from Xiamen University, Xiamen, China. She will be presenting the One Health strategy at Xiamen University. Please, Dr. Xiuping, the screen is yours. The time is 20 minutes.
Okay. Can you see the slide?
Yeah.
Okay, thank you. Good afternoon, everyone. Thanks a lot for the opportunity to participate in this communication. Here, I'm going to talk about One Health strategy at Xiamen University. And in our university, the Global Health Center is the institution who carry out One Health strategy. Professor Shizhen Zhou is our director, and Professor Temu Chen is our deputy director. There are four staffs in our team, and including 7 PhD students and almost 23 master students. This is a team that covers many fields, such as the parasites, infectious disease, and preventive medicine. And we also have some students from the mathematics and computer technology. And here is the contents of our research. It is divided into 3 sections. The first section is theory formation. We choose the 4 system diseases, including almost 20 diseases, and conduct almost more than 80 mathematical models to form the disease transmission. And then we use these models to do the method application, such as the epidemic trend analysis or construct of early warning mechanism or invention simulation and optimize the prevention and control method. And the last, based on these results, we made some achievement transformation, such as build some platforms and made some tools for the medical staff to better work. So here, I choose the tuberculosis as an example to tell a little more detail on our content. Tuberculosis is a global disease, so we choose the 10 high burden countries, TB cases, to find out the epidemic trend in the future. And by using the 3 models, we found that there are some countries that declines in the future, such as China or South Africa. And then we go further into the analyze. We choose 2 large provinces of China and made some epidemiology characteristics analyze, including the time, space, or geography distribution. One of the results showed that the college and high school students are at high risk of TB. So we get another step into the analyze. We do some research on the college students, on all of the students of China. We base on the TB nature history and build an SEIR model to find out the transmissibility of tuberculosis. We found that the total student TB cases transmissibility is 1.72, which we can use this number, effective reproduction number, to calculate the transmissibility. We also call it REFF, and which means one student tuberculosis case can effectively one patient can effectively transmit to almost 2 persons. There are much higher at non-student population, but once there an outbreak, TB outbreaks in the school, the number may reach almost to 10. That's very interesting. So here is the transmissibility calculation on the tuberculosis. And then based on the 3 research, we found out the tuberculosis epidemiology characteristic. So we went to the further analyze. It is the intervention simulation. What we think the first method to control the tuberculosis is that the diagnosis delay. We also collect the data to do the conduct the SEIR model and to calculate the transmission of TB, and why we short the tuberculosis diagnosis delay by different percentage. We can see different results we got, which means by reducing the delays in the diagnosis delay period, there has the potential to achieve the end TB strategy target. This target is set by the World Health Organization, but we can see it is not the only way by shorten diagnosis delay, because in some regions, even though the 100% reduction in diagnosis delay, it won't be able to reach the NTB's target in the future. You can see here, 100, it cannot be reached. So there must be another method or some other method to help to control the tuberculosis. So the other way we thought is the isolation. We choose the 4 outbreaks of TB, of tuberculosis, and we conduct 2 SEIR models to calculate the transmissibility. We found that the patients isolating 100% in the first month of the outbreaks, it can result in case reduction of more than 80%. So isolating is the most efficient method to control TB. Here is the intervention simulation. And then after this analyze, we can got some conclusion and can give some advices to the government, such as the disease surveillance, and we can make some disease surveillance in the high-risk population. And once there is an school tuberculosis outbreak, the most effective way is to isolate the patients, and the early control MTB spreading will effectively reduce the use of medical resource and government funding. And also the social activities are also important factors to affecting the spread of mycobacterium tuberculosis. This is some advices we give to the government, and the CDC, we can call a Center of Disease Control, can make some efficient control method on the most high risk population to control the tuberculosis. Here is just one disease of our research on. There are a lot of diseases we just showed you about before. We also do some research on the COVID-19, dengue, or the influ, and to make some suggestions to the government or the CDCs. And also, we during the COVID-19, we also made some vaccine strategy for the government to control the COVID-19 pandemic. So, and then based on the achievement, we made some transformation, such as the forecasting and early warning platform on the COVID-19 and on the global monkeypox surveillance. Here is the screen of the platform. And also we have made some calculators on the risk of the disease and on the reproduction number calculate, and to help the medical workers work to a better work. And we also made some tools to make them to draw pictures or draw the graph, and do some time organize, and made some map and geography analyze assistant. That's all the tools that can improve the actual work efficiency of medical workers. In fact, some of our partners are already using these tools in their work system to help their work. And during the pandemic, we also made, according to the demand of the government, we also made some medical service demand platform and some population prediction for the COVID-19 screening, and to help the government to change or to adjust their strategy on the disease. Here's the transformation of our achievement. And then our team also had some cooperation with the Peking University or with the Duke University, and made some communication with different levels, Center of Disease Control, and also made some communication with the companies. Here is the cooperation pictures. And here is our partners locating map of China. And our partners are from government and Center of Disease Control and university, hospital, and company. We help them to do some research on the infectious disease, or in the past 5 years, we also got some fundings from them and have published more than 120 articles in the journals. Here is the chief introduction of our team. Thank you for your attention, and thanks.
Thank you very much, Dr. Xiuping, for your very informative presentation. I think your university has developing many research that is useful for your country, and I think we have a lesson learned from your research that to end TB in one country is possible, because in your research you can even prevent the disease by isolation. Yeah, I think it's very interesting. And and also you have developed many I think something like forecasting, risk calculator. I think it's a digital thing, yeah, in the disease prevention and control. Thank you very much. And our next presenter is Professor Kumthron Malatham from Mahidol University, Bangkok, Thailand. Good afternoon, Professor Kumton. Please unmute your mic. And he will present managing antimicrobial resistance through One Health approach.
Okay. Now, can you see all my slide?
Yes, I can see it.
Okay.
Let's go ahead.
The problem is I don't see my slide. 1 second. All right. So you see my slide?
Yes. It's very clear.
I don't see. Let me see. Let me stop my sharing. Okay. All right, here we go. All right. Thank you for the organizing committee for inviting me to give the talk here. So within 20 minutes, I would like to talk about the management of antimicrobial resistance through One Health approach. We all know that we are connected with the nature. Everything in the world is connected. Here you see that the microbes live in the world, and they also with us and animals, and so we live in the environment. So this is a picture from the clinical microbiology newsletter long ago, showing the connection among the humans, animals, and environment. So we're going to expand this a little bit deeper. Well, if this is the connection between things like animals, humans, and environment, so the organism which is now resistant to antimicrobial agents, they can live in environment and contaminate to the life, except for example livestock. So we eat them, we live with them, we grow them, so we spend our life with them for how long, so we can get the resistance back from both the animals and from the environment. And sometimes we get to admitted to the hospital. In that environment, there are so many patients with multi-drug resistance. So the transmission of drug resistant organism occurs through direct contact among people who live in the hospital. And then with that, the organisms that are resistant to many antimicrobial agents can contaminate the wastewater, the infectious waste, or even to the water system, and then recontaminate the environment, and then it's back to the animal, and then even back to the people in the community. So this is a very complex antimicrobial interaction across One Health sector. This is an example of how resistance occur in farm animal. This is a study of the MCR1 in China, which demonstrates that the mobile resistant gene, mobile colistin resistant gene has occurred in the farm animal that we use as our food. Then people get the MCR1 carrying bacterium in our system, and then the MCR1 will be transmitted through other people. The major driver of antimicrobial resistance is actually the use of antimicrobial agent itself. It was found that animals in the USA consume more than twice as many medically important antibiotics as humans. This is a picture of only one in the country, and this picture probably similar all over the world. That is, majority of antimicrobial use is in animal. And here's the data of the World Organization for Animal Health. They have annual report. This is the latest report comparing the data from 2017, 2019. We can see the total quantity of antimicrobial agent that the consumed in livestock is over 77,000 tons. And this is data from a study which show you very similar number, that is 76,000 tons of antimicrobial active ingredients has been used in animal livestock all over the world. And more than that, 3/4 of antibiotics that used in livestock are antibiotics that are categorized as being medically important for human use, for example, like penicillin groups, quinolones, aminoglycoside, macrolides. So if you look at the proportion of each antibiotic that has been used in the animal, this is antibiotic that were given by oral route. So majority would be like tetracycline, penicillin, macrolide, amphenicol. And for the amphenicol, we don't use in human animal. And sulfonamide are used a lot as well. But fluoroquinolone, it seems to be not so much in that as compared to tetracycline and penicillin. And this is by injection. Injection that comes to the penicillin group again, and fluoroquinolone comes up to 5%. Aminoglycoside is 10%. So with the huge heavy use of antimicrobial agent in agricultural sector, there have been big debates among people in the health science center that deal with human health and the food producers, and also in academia in the agricultural sector, that actually the antibiotic resistance that occur as a result of antimicrobial use in agriculture would affect human health. There was a review made by teams in the United Kingdom long time ago, about 10 years ago. They found that about 139 academic studies that the review found, only 7 or 5% argued that there was no link between antibiotic consumption in animals and resistance to humans, but 72% found evidence of a link. So I will show you some link here. The global antimicrobial resistance driver and ecological country level study at human animal interface. The finding in this study is interesting, that there is a correlation between carbapenem resistant Acinetobacter baumannii and consumption of carbapenem and cephalosporin in humans. And also antibiotic consumption in animals is also correlated with the prevalence of carbapenem resistant Acinetobacter baumannii. Carbapenem resistant Pseudomonas aeruginosa is also associated with the use of carbapenem cephalosporin, both in human and also in the animal. Third generation cephalosporin resistant E. coli, or known as extended spectrum beta-lactamase producer. This is again, you see the correlation between use of these agents in humans and animals. Oxacillin resistant Staph aureus, or MRSA, is also related to the consumption of oxacillin in human and antibiotic consumption in animal. The vancomycin resistant Enterococcus faecium associated with consumption with glycopeptides in human and also in animals. It's been long recognized that the use of avoparcin in the farm animals lead to the increased prevalence of vancomycin resistant enterococci among workers in the farm. And the ban of the use of avoparcin in the farm in the opposite way is all correlated with the reduction in the prevalence of VRE among farm workers. This is a study from Thailand. It is one study that I think it is very interesting, that the author took the commercial duck meat production and look for salmonella. They got a lot of salmonella strain from the duck meat, and see that 100% of salmonella found from the duck meat are resistant to sulfamethoxazole, and some are resistant to something like linolenic acid, which is the primer of fluoroquinolone. So it is not uncommon to see fluoroquinolone resistant infection in humans. Interestingly, in addition to the resistance to antimicrobial that we use as antibiotic in humans, these some are also resistant to antiseptic like benzocaine chloride, which is used commonly in healthcare system. You can see that it might the minimal inhibited concentration of benzocaine chloride is higher than 128 microgram per ml for most of the isolate. So the MIC 50 is 256 and MIC 90 is 256. So this is very interesting because we use benzocaine chloride all over the world. Here's a study about the antibiotic contamination in the environment. So we are moving to from the livestock to environment. A study was largely from South China. They found that the antibiotic concentration that most likely exceeded predicted noefic concentration for the development of antibiotic resistance observed in wastewater and influence and effluence of wastewater treatment plants from hospital, municipal, livestock, and pharmaceutical manufacturing, and also aquatic environmental compartment. So the contamination of antibiotic from many parts of the society is potentially causing antibiotic resistant bugs in the environment, and finally we are afraid that these resistant bugs will come into livestock and also in human as well. So the highest risk for development of resistance was in tap or drinking water of the Western Pacific region and China for ciprofloxacin. Here's an example of contamination of the resistant bacteria, not only the antibiotic that go into the environment. The researchers have found that in India, they took the samples from the environmental water from many parts of New Delhi, and they found that a lot of bacteria like conventional enterobacteriales, E. coli, Klebsiella contain New Delhi metallobeta-glutamate 1, and more than that, this NDM1 was also found in Shigella boydii and also Vibrio cholera, which is not the enterobacterium. So you can see that the contamination of resistant genes occur throughout from within hospital, from hospital to community, within community, and to livestock, and also to environment as well. This is the study from Thailand. We see that we see one phenomena here, that the NDM and MCR stay together, and also OXA48 lines, which carry the most worrisome antibiotic resistant phenotypes, also stay with the MCR, and MCR resides in the livestock. And these isolates were found in clinical isolate from humans who are sick in the hospital. So we can see the connection between resistant bugs and also with the environment, with the livestock. So this is our approach. In Thailand, we have a national strategic plan on antimicrobial resistance. For the first edition was in 2017 to 2022. And now we are in the second edition, which is similar because we use the same approach. We have National Policy Committee on Antimicrobial Resistance, chaired by high-level multi-stakeholder. We use a multifaceted strategy, including surveillance, regulation of distribution of antimicrobial both in human and non-human sector, antibiotic control, antibiotic resistant control in human and agriculture. See, we can we look through everything. And with National Static Committee, the plan is that we integrate every sector that involves human sector, environmental sector, animal and food sector, altogether. And here is a summary of the highlights of what we found as a result of carrying the National Action Plan on antimicrobial resistance. We see the antimicrobial consumption in human decreased from 2017 to 2020. That is 33% down. Antimicrobial consumption in animal also about 40% down as well. The knowledge or awareness of people on AIM increased from 23 to 25%. But anyway, we have not achieved significant reduction in the prevalence of drug resistance in human and animal. So for this part, we think the pitfall is that we still have a lot of work to do in the healthcare sectors, because these are the prevalence of, you see the, for example, carbapenem resistant Acinetobacter baumannii. This is a hospital organism, not a community hospital, community organism. These are hospital organism. Also, ZRE in our country is also still the hospital pathogen. So we think we need to strengthen the human sector for more than this. So the main concept of the second National Action Plan is very similar. So we're gonna we need to reduce the impact of antimicrobial resistance through cooperation of all sectors, like through the One Health approach. That started from the first in NAP is similar to the first one, is that using the surveillance system using One Health approach, regulation and antimicrobial consumption. Okay, this is the same as in the first part, but we go deeper in detail, like in the sector of hospital, we're gonna strengthen this part so that we hope the prevalence of drug resistance in this sector will decrease further. For the last part, I would like to talk about the infectious virus and that antimicrobial resistance. We learned from COVID that we use a lot of PPE. See, and there was a lot of study that our personal protective equipment has contaminated the environment all over the world. Looking at the AMR management, we need to use PPE as well, like plastic gown, gloves, and for the contact precautions for the antimicrobial resistant carrier in the hospital, we require that most items should be single-use items. So with the AMR control, we might achieve the control, but in the other side, we also have to look for the impact of using PPE and also other resources that might affect the environment in other ways that is not related to the infection, like the increasing waste in the environment, which lead to a lot of problems there, like microplastic or some other things like climate change and so and so. So we are living in the interconnected world among microbes, humans, environment, plants, and so we live together. So we need to work in concert, all sector all together, so that we can we can set the antimicrobial resistant bugs under control, while we don't destroy our lovely planet's environment. Thank you very much.
Thank you very much. I think we have insight here based on your presentation that antimicrobial resistance is also a big problem in human, yeah. And I myself got information that there are correlation between consumption in animal for antibiotic and correlated with antimicrobial resistance in human. Thank you very much, Professor Kumton. And now we move to the next speaker. We have here Dr. Frederic Cake from France, yeah, from CNRS Collège de France, Paris, France. Good morning, Dr. Frederick.
Good morning. I am not able to share my screen, so can someone help me share my screen?
Okay, Debri, can you?
Okay, it works. Yes.
Dr. Frederick will present the anthropological dimension of One Health and emerging diseases. Please, the slide is yours, or the screen is yours, Dr. Frederick.
Thank you very much for your invitation to this a very interesting workshop. So I am a social anthropologist based in Paris, and I want to present some thoughts and research on the contribution of social anthropologists to a One Health perspective. So as you know, the behavior of humans in the transmission of pathogens between animals and humans is at stake. But I want also to argue that we need to target the representations, the cultural representations. So as you know, 70% of emerging infectious diseases are zoonoses. These are caused by pathogens that mutate in animal reservoirs and cross species borders or species barriers before spreading between humans. And so in the last 20 years, global health initiatives have aimed at anticipating the emergence of zoonotic pathogens before they become epidemic or pandemic. And social anthropologists have been called to assess the role of human behavior in these spillover events. So, for example, this is a framework that I have built with some microbiologists and epidemiologists, published in 2014 in PLOS Pathogens, on the different factors that amplify the mutations of pathogens from animal to humans. So changes in land use, changes in animal management, changes in variability in climate and weather. And then these are environmental factors. And then as you come close to the middle of the circle, you have more human factors, such as contact between humans and animals. So what I want to argue, what I want to ask is, what is the contribution of social anthropology to assess these contacts between humans and animals? So how does the management of zoonosis reveal and transform relations between humans and animals? Are local knowledges of animals obstacles or assets in the control of zoonosis? And how can early warning signals of diseases be perceived at the interface between humans and animals? And how local societies can help us build global systems of anticipation? So my work in the last 20 years has focused on avian influenza, which is a disease, respiratory disease transmitted from wild birds to domestic poultry, to pigs and to humans, with returns also from humans to pigs and poultry. And I have proposed this framework to understand why avian influenza challenges our representation of what is a bird. So if we start from a European perspective, there's a big separation or a big gap between birds as commodities that we eat and birds as living beings that we admire when we look at the sky. But when there is an avian influenza outbreak and the health authorities have to kill often thousands or millions of chickens to stop the spread of the zoonosis, then there is a tension between these two representations of birds. And this tension is often manipulated or used by the media because it produces a lot of emotion. So we see animals that are transformed into waste. This is a picture that I took in 2009 in Hong Kong, where I did my research. And so my hypothesis is that to mitigate this tension and to explain the public why there is this strategy of culling chickens to avoid avian influenza pandemics, there are different actors that are involved. So some see birds more as commodities, like consumers, agriculture department, media, health department. I even work with religious authorities. And some see birds more as living beings, such as retailers, farmers, food industry, bird watchers. And in the middle, there are microbiologists, veterinarians, physicians who are able to follow the mutations of the pathogen and to do ordinary surveillance. So I argue that ordinary surveillance is an alternative to the massive killing of chickens, which is not acceptable for the big audience. So if you look at birds as commodities, in Hong Kong, the problem is with live poultry markets, as in many countries of Southeast Asia. So this problem of the contact with live chicken has been solved by the authorities with campaigns of prevention. And there is also a risk of transmission from chickens to humans at the level of the farm. And this problem has been solved by what is called sentinel chickens, which are not vaccinated, so as to allow surveillance of the mutations of pathogens in the farm. And now if you look at birds as living beings, I worked a lot with bird watchers who told me about some religious practices that have amplified or that have multiplied the number of cases of wild birds with avian influenza. So in Hong Kong, there is a bird market where people can buy birds either for song or for fight. It has been prohibited, but also for rituals, such as this ritual of killing a rooster and spreading blood at the beginning of a Taoist festival, or this Buddhist ritual, excuse me, this Buddhist ritual of releasing birds. And many of the birds that are released in the middle of cities in natural parks are found dead with influenza. So here there are prevention campaigns to regulate these religious practices. So starting from these cases where we see that the European distinction between animals for food and animals to live with, or animals as pets, doesn't work. And we have built a team that compares the different representations of animals and the perception of zoonosis in different societies. So the questions we ask is, how do humans living with animals conceive of zoonotic pathogen? How do they control borders between wild and domestic animals? And how do they manage the bodies of sick animals? And we rely on the hypothesis of a prominent anthropologist based in my lab, Philippe Descola, who has made a distinction between 4 ways to relate humans and animals in different parts of the world. So we have tested this hypothesis in 4 different sites in the world. So mostly in Asia Pacific, I'd say. So, and in these different sites, we have started with the question, can animals transmit disease to humans? So working with Aboriginal Australians, the answer is very different from working with elephant breeders in Laos, or working with cattle farmers in Mongolia, or working with people dealing with camels in Qatar. And so we move beyond these figures to understand the practices and representations of animals in these 4 sites. So Australia is a very interesting site to investigate because it's where the first emerging virus transmitted from bats to humans has been studied in Hendra. It's a city near Brisbane in Australia. In 1994, there were 89 deaths among horses and 1 veterinarian who died. So it was found that this virus was spread among bats. So there were measures to chase the bats from these trees. And then there were many studies that found that emerging pathogens or viruses were found in bats. So we knew that for rabies, but there were other viruses such as Nipah, Hendra, and then coronaviruses like SARS. And virologists worked on the reasons why bats were good reservoirs for emerging pathogens. So it's mostly because there's a wide diversity of species who live in the same environment in caves or trees, and they have shared viruses for millennia without being sick. And now they get close to human habitats because of deforestation and consumption of their meat, what is called bushmeat. And they have a high longevity, so they can host these viruses for a long time. And what we have studied in our research is how Aboriginal Australians have lived also for millennia with bats without being sick, and sometimes consuming bats. So the consumption of bats is regulated by prohibitions. So when we asked an Aboriginal artist to lead us in caves where we found these images of bats that testify the long coevolution between humans and bats in Australia, he made a painting, and he smoked this painting to purify the bat. So that's really interesting for us. What does it mean to purify a bat if it's not done through biomedical practices, but through totemic practices linked to images? Then we also worked in Mongolia, and it's a classical site for One Health approaches, particularly through the seminal work of Jakob Zinstag in Basel. So Mongolia is a post-communist country that has 46 million animals and 3 million humans, and 1/3 of its economic productions comes from cattle. And so controlling the health of cattle is very important for the health of the country, of the human population. And so the cattle is threatened by brucellosis, which causes abortion, and there has been vaccination for a long time. But there are 2 other infectious diseases that are new and that cause very severe outbreaks, and the Mongolian government is not very comfortable to manage these outbreaks. So one is anthrax, and so the technique is quarantine and culling. And it's very similar to foot and mouth disease because it's very, very rapid. And so it is very problematic for herders to see this massive culling of animals, because for Mongolian herders, when cattle is killed, the blood should not be spilled on the ground. So how do we integrate these representations and practices in our management of zoonosis? So when we did interviews with the herders, the cattle farmers, they said that humans have bodies and souls and animals have vital breaths. And they talked to us about the contact between the cattle and the wild animals like gazelle. And they also said that the bones of animals contain human cells, so they should not be broken or thrown away. And they also told us that the infected carcasses should not be burnt or buried. And then the third research we did was on elephant tuberculosis in Laos. So the awareness of the transmission, of the potential transmission of tuberculosis between elephants and humans was raised by the deaths of 2 elephants in a circus in the US from tuberculosis. And they had the human mycobacteria of the tuberculosis. And in 2011, a preliminary survey in Thailand showed that there were also cases of mycobacterium in tuberculosis in elephants, and that there was a potential transmission to the people who raised these elephants, who are called mahouts. And then in 2012, a study showed that 34% of the elephants in Laos had TB. So of course it's a major issue for Laos because it is called the country with 1 million elephants. So it is not the case anymore. There are probably more like 800 to 900 elephants, and half of them are captive. They used to be raised for logging, and now they are raised mostly for the tourist industry. And we also did a survey with these mahouts, these elephant breeders, to ask us about their representations of these animals. So they talked about the spirits of these animals, Phi. They told us how they learned to be attentive to animal spirits when they captured elephants in the wild. And they told us about the measures they have of elephant health by their size. So, for example, TB is not perceived through respiratory troubles, but rather by the decrease of the size of the elephant. And what's very interesting is that the mahouts didn't believe that TB could be transmitted from elephants to humans, although they were the first potential victims of this transmission, and that's why that's because they were afraid that the elephants would be killed if they were suspicious. Now I'm talking about the fourth research we did in Qatar for Middle East respiratory syndrome, which is caused by a coronavirus transmitted from camels to humans. This coronavirus emerged in the Saudi Peninsula in 2012. More than 300 persons were infected. 30% of them have died. Fortunately, it remained in the Saudi Peninsula. There were a few cases in Europe, but always traced to Saudi Peninsula. And camels have been found positive to MERS-CoV from the Sahel to Central Asia. And so the problem is why this disease emerged in Saudi Arabia and not in Sahel or in Central Asia. There was no bat found with MERS-CoV, by contrast with SARS-CoV or other other infectious diseases. So it is still an enigma to find the animal reservoir of this disease. So what we did is work with camel breeders and study the behavior that could have transmitted the MERS-CoV to humans. So we did some investigation with the milk but epidemiologists didn't find any MERS-CoV in the milk. And then we went to the camel market. Some MERS-CoV was found in the camel market, and we wanted to work with the slaughterhouse where there's a lot of imported camels, particularly from Australia and Central Asia, and also migrant workers from Pakistan, but we couldn't do this study. And what we did was to study the camel races, where rich Qatari are at a distance of the camel, so they cannot even go on the back of the camel for human rights reasons, so they use robots. So it was interesting. It was a difficult study to lead, but it was interesting to see how a relation of proximity and distance in Qatar were very different from what we expected in Europe or also in Asian countries. So as a conclusion, pathogens emerge among many invisible entities perceived by people living with domestic animals. And so we are sensitive to representations of spirits that people bring when they talk about zoonosis. Zoonosis revealed the uncertainties of living with animals coming from wild environment, as we saw with bats or gazelles or even wild elephants that are domesticated by the mahouts in Laos. And then we argue that global health intervention makes sense in local environments, raising concerns of conservation and sustainability. Thank you for your attention.
Thank you very much, Dr. Frederick. I think it's very useful and informative for us in terms of One Health. We have a different view about One Health in terms of anthropological dimension. I think it's very interesting, and you have tell us about the disease across the countries with different view. And we move to the last presenters this afternoon. We have here Dr. Anne Laure from Montpellier University, France. Good morning, Dr. Anne. Yeah. She will talk about the Presode initiative.
Good morning, all. Let me just.
I can hear your voice, Dr. Anne.
Yeah. Could you hear me? Yes.
Yeah.
Okay.
I can hear your voice clearly.
Yeah. Okay.
Yes. Please, Dr.
Okay. Let me share my presentation. Okay. Could you? Apparently, you cannot see my screen. Could you see my screen?
Yes, Doctor.
Okay, I will try to put in full screen. Okay. Could you see? Is it okay? Okay, so I will talk about PREZOD. Thank you to give me the floor. So PREZOD is for preventing zoonotic disease emergence. So it is an initiative. So I'm working at IRD, so I'm director of research at IRD, and I'm the focal point for Southeast Asia with Flavie Goutard from CIRAD. And so you can contact us if you have some question, and also check the website that I will give you later. So preventing the PREZOD initiative is an international initiative which address all the challenge related to the prevention, surveillance, early detection, and rapid response to risk of zoonotic pandemics. So this initiative was launched at the One Planet Summit on biodiversity, discussed by the French president, the president of the French Republic at this summit in 2021. And PREZOD aims to contribute to the new One Health high-level expert panel set up by the different organizations, FAO, WAO, WHO, and UNEP. So this initiative wants to change the paradigm and work more on the preparedness and the prevention more than work on response, because as you know, and today we have a lot of initiatives to work, and also research project to work on response. So the key objective of this initiative is to give the priority to prevention versus only response, to support local action for global solution, to build a resilient socio-ecosystem, to also push the stakeholders to be involved in the process, in the discussion, using participatory approach, to also implement research and development and develop a nexus, ensure also a science, society, policy dialogue. So the spirit of PREZOD is really to implement a co-construction approach. And so this initiative, the co-construction, started in 2022. And for this, we perform some regional and international workshop everywhere in the world, and to share vision, and also to identify the strategic pillars of this initiative. And we define all together a shared strategic agenda that you can find on the website. And also we established a shared governance framework. So the PREZOD initiative, the ambition of this initiative is, of course, to be in line with the One Health approach. And for this, to work with countries and with other initiatives, it is really important to be in coordination with all the other initiatives, not to be redundant. And this to prevent animal-borne pandemics while ensuring food security and livelihoods for the poorest communities. So here you have the different pillars which were identified all together after the different workshop. And so the first pillar is focused on the evaluation of the risk. So it is important to understand zoonotic risk and risk activities. The second pillar is to co-design solutions to reduce the zoonotic risk. The third pillar is to strengthen the early warning system to detect zoonotic risk. The fourth pillar is to implement a prototype, a global information system for surveillance and early detection in the different countries, and of course in collaboration with the specific stakeholders involved in the One Health surveillance. And the fifth pillar is to engage stakeholders and to co-design the One Health network and policies. So since 2021, as you can see here, we have a growing number of partner signatories. So more than 250 institutions in over 77 countries. More than 18 countries also sign this supporting letter. So this international initiative, in fact, will thus constitute a scientific and operational framework to coordinate research projects, health network, and operational action, a platform for sharing knowledge. And so this will be based on data acquired through the past, current, and future projects, and also to capitalize on success story and pilot action in the different regions of the world that we could share within this platform. And also we want to implement a resource center available notably for the One Health high-level expert panel, and to facilitate in particular the development of recommendation for decision makers by the letter. So you have here the website. So we implement the PRESOD governance since last year, 2022, we started. So we have a PRESOD General Assembly, and so the next one will be in November. We also define an international steering committees. And inside we have the 5 representatives for the 5 pillars working groups. We have also donors committee, an ethics committee, and a scientific advising board. So we also implement different working group on communication, international data, regional focal point working group, labeling working group, events working group, partnership, and fundraising. And all these working groups are coordinated by a secretariat and a general secretariat. So we have also different group and link with WHO, but also FAO and World Organization for Animal Health. And we also promote the prevention via high-level events, like you can see the list here. So we try to make advocacy for the different aspects that PRESOD wants to develop. And so we also have an international recognition we've mentioned in G20 and G7 health minister reports. And we collaborate with public health organizations like Global Fund at global and country levels. And we promote prevention in the pandemic agreement, which is under negotiation. So PRESOD wants also to support PRESOD members and international organizations. And so the goal is to co-develop the solution, to do evidence-based, of course, recommendation, demonstrate the impact, to engage the community and civil society, and also to engage financially and politically the different countries. So we co-design also the process with the countries and the different stakeholders, but also the community. So it is important at the regional, but also national level. And the PRESOD Secretariat could support members in facilitating project proposal and in which we would support the co-design process. We have also a scientific framework and impact-based approach. The framework, in this framework, we identified key elements to implement to prevent the next pandemic. And we have we would like to have a PRESOD impact pathway to demonstrate the impact of the activities, which is very important to show the impact of the initiative on the prevention and surveillance. We will also use this scientific framework to for the basis of planning the planning of the activities. So PRESOD also try to find funds to make some to support some projects. Like the support of different projects in countries by co-funding. So in this framework, we started a project with the name is PREACT for PRESOD in Action, and this project is supported by the Agence Française de Développement, French Agency for Development, and in this project. The idea is to support the national strategy and policies to prevent the emergence and spread of zoonotic disease, of course, while ensuring food security and community livelihoods, to define and implement activities to meet the need identified in each country in terms of assessment of the risk, in terms of reduction of the risk, and in terms of implementation of surveillance and early detection strategy. And so in this PREACT project, the first phase started in 2023, entitled AFRICAM. And so this project is multicentric in Cambodia, Cameroon, Guinea, Madagascar, and Senegal. The second phase will start started this year, at the end of this year, at SAMCO. In different regions of the world, also South America, RDC, and Laos and Thailand. And the third phase is still in preparation for 2025. So just I will give you a brief summary of AFRICAM project in Cambodia, since I'm the coordinator with Flavie Boutard from CIRAD, and we have as a national focal point so Dr. Krang Sidon from CDC, the CDC of Cambodia. And so this project, of course, have a framework defined by the IFD, the founders. First, it is we will work in the framework of the three first pillars of PRESOD, and we will have, of course, transversal activities defined in the fifth pillar. We will focus on One Health, on zoonosis, on climate, gender, and biodiversity. They ask us to build the project on the previous and ongoing project. So it was really important to make an inventory of the One Health project developed already in this country. And we should also co-construct the project with the local partners. And one of the main mission is to, of course, to reinforce the capacities and the surveillance system of the country. So our objective for Cambodia was based on the fact that water is a key element in this country, as many countries, and said that climate change and human activities can have an impact not only on the environment, like here you can see the Tonle Sap lake in Cambodia, but also on the wildlife, the vectors, the ecosystem, and of course on the circulation of pathogens. So in this framework, in fact, the objective of the project was to study the risk of emergence of zoonotic disease impacted by the hydrological dynamics, climate, and environmental change in diversified ecosystem representing key animal, human, and environmental interface. And also the second main objective was to implement activities to reduce the emergence of zoonotic risk and reinforce the existing surveillance system towards integrated One Health surveillance. So, of course, the idea here was to, as I said, to work on the different pillars, so pillars 1, 2, and 3. and to work on the transversal activities which are capacity building and strengthen the One Health surveillance. And we selected 3 sentinel sites relevant for surveying zoonotic pathogen transmission. And so these sites are in different provinces, which are Batamang province, Tung Treng province, and Kandal province in Cambodia. And we based this selection on the different project, previous project or ongoing project in this site. As you can see here, Zoco, what else becoming, so it's different funding project in this site. So we also define the different components and activities according to the different sites. And just to have an overview of what we started to do in the Batamang province, first we will work on the component 1, so risk assessment. So we will study the circulation of pathogens. We will also study the zoonotic risk factors related to human activities. We will study the zoonoses that they can detect in the Batamang hospital, and we will make inventory, and we will try to implement diagnostic tools to be able to go further and to detect more zoonotic cases if necessary. And we will make some ecological modeling for risk factors identification and, of course, capacity building. So you can see here on the map the different, we will study a gradient from the Batamang city here until the humid natural area in the close to the natural reserve of Prektual in this province. So we also identify different bacteria, parasites, and viruses that will check in humans, but also in different animals and in environment. And here we also define a sampling flow chart in the site to do seroprevalence study in humans. We will study the circulation of pathogen in domestic animals and in environments, but also in rodents. And we will make an inventory of mosquitoes and ticks in this area according to the season, also to follow by a longitudinal survey the circulation of pathogen. This study will help us to identify the risk factors and to work with the population how to determine some activities to decrease the risk of transmission. So the component 2 is risk reduction. As I said, we will work on the different results that we will collect to co-construct a prevention strategy. And so we will make for this different awareness workshop, and we will train the local communities to know better the One Health approach, and we will develop participatory workshop to define the strategy for risk reduction, and we will co-construct and deploy One Health intervention to reduce the risk. So we did not define yet what kind of intervention, but because they will be defined after this participatory workshop. And the last component is based on the development of One Health community-based early warning surveillance. And the idea in Batamang is to make a pilot study through participatory session, and also to make an inventory of the existing preliminary studies and also make a participatory workshop for One Health surveillance system, and try to co-construct with the community, but also stakeholders for the in perspective to integrate this pilot system if it is relevant in the national system. So we will also develop the competence center for satellite data acquisition and processing. So this part is developed with the Institute of Technology of Cambodia, with the participation of the KEOPS laboratory and Espace Dev lab. This part is supported by Vincent Herbretot of this unit, and we will make capacity building on surveillance practice and field context-specific diagnostic. So here you have the main partners, and of course we will work in collaboration with the different institutions at the national level, and especially with the institute, the platform for One Health, and the different Ministry of Health, Ministry of Agriculture, Ministry of Environment, FAO, and WHO. And also we will work with the provincial and district level and the community level, and we will be in connection with the university to involve the students in this project, in the different study. Okay, thank you for your attention. And if you have some questions, don't hesitate.
Thank you very much, Dr. Anif, for your very informative presentation. And yeah, Dr. Anif is the last presenter this afternoon. And now we have time for question and answer. Please raise your hand, or you can also write in the question and answer in chat room of the Zoom. Yeah, in chat room, we have a question from Norvianto, Indonesia, but he doesn't mention to whom this question is. He asked about, I can read here, since One Health talk a lot about the subject of balance between human and animal health, with human health as a main topic, how about the application and concept of One Health for the components in an ecosystem such as plants, fish, insects, or microorganisms? Thank you. I think this question is for, I don't know.
Maybe I can try to answer quickly. I think it is very important to also yes, you're right. You have totally right. Even if we say that it is One Health, the focus is human health, and this has to be changed. And it is really important to consider and to develop projects also to consider the impact of the anthropological activities on the animal health, but also environmental health. And so it's a reason why we need the involvement of all this domain in the different initiative of project. And so now for African, for example, we identify the pathogen based on the human health. And so we have to discuss with the Ministry of Health. Maybe it is important also to add other pathogens, but more specific for animals. And maybe also plant health. Why not? It is important also.
Do you also have an activity related to plants besides animals?
Yeah, in fact, we are working with people in my institution, yes, on plants and especially pathogen of plants. And so I think it is, I'm not specialist, but I think that it is really important also to consider this aspect. Yeah.
Okay, thank you, Dr. Anne, for your answer. And we have other question in chat room, but it is the question for the committee of this webinar. Will I get the certificate for attending this webinar? Mas Debri, you can answer this question. Debri?
I think Kimberly can answer this question. Kimberly, are the participants get the certificate?
Okay. How about the certificate of the attendee? Yeah. Debri, I think you should discuss with the committee about the certificate of this webinar. The participants of this webinar is not only from Indonesia, but also from other countries, especially from ASEAN countries. And there are so many speakers in this webinar, so it means there's so many information also they got from this webinar. And I think it's better if the participant get the certificate as a proof of the attendance.
Okay, Pak Mugi, your suggestion will consider.
But make sure that all the participants please fulfill the attendance form, yeah, in a link. I think the link has been shared by the committee. Yeah, please fulfill the presence form, yeah, in the link. And then please feel free for a discussion or for make a comment or ask a question. We have here Professor Padet, Dr. Xiuping, Professor Kumton, and Dr. Frederick and Dr. Anne, who are ready for to answer your question or discussion. Debri, do you see a person raise a hand? Yeah.
Nobody, Pak.
No one?
Yeah.
If there is no question, maybe I will ask to Dr. Anne again. May I, Dr. Anne? About the project of PRIZOD, yeah, PRIZOD initiative.
Yes.
It is very interesting project that I think if we conduct this project effectively, the next pandemics caused by zoonotic disease, I think it will be prevented. And do you have any plan to expand the project to ASEAN countries besides Cambodia?
In fact, the AFD project is already planned for the next year. I said that the third phase is already in discussion, but they already identify the different countries. But it is important that if you, Indonesia and institution in Indonesia wants to have the opportunity and to find funding and co-funding or co-funding through PRIZOD, in fact, you need to sign the supporting letter. Just a letter. It is not no particular things that you have to do, and just to sign the letter. After that, you will receive all the information and all the possibilities, and also you can discuss and participate to the General Assembly and to exchange and see the opportunities that President can help to develop. And so we started to also to try to find funding through the NIH, for example, or other call. And so all this information are distributed to all the organization and also countries when they are members of President Initiative. So don't hesitate, and it is really easy on the website to do, and also to have the information.
What institution should contact the principal? I mean, maybe contact you, because in Indonesia there are many institutions that collaborate to handle zoonotic disease or pandemics. For example, in Ministry of Health we have Directorate of Health Quarantine and Infectious Disease, and also we have a research body in BRIN.
But yeah, in fact, you can for the countries. Of course, I don't know what ministry of at what level in the government you have to sign this letter. For example, in Cambodia, it was the Ministry of Foreign Affairs and International Collaboration. But also you can sign, the ministries, different ministries can sign also, and to have a representative of each ministry in the President Initiative, and to attend, for example, the different meeting. And for the institution, organization can be a university, can be a research institution or NGO or whatever. Of course, it is not individual participation, but more organization. So, but you can contact me, no problem, and I will help you in the process.
Thank you, Dr. Anne. And I have also a question to Dr. Xiuping from China. Are you still here, Dr. Xiuping? She doesn't respond. Okay. Is there any participant who would like to ask or discuss or comment? Kim, do you have something to say in Zoom as a closing? No? Okay, ladies and gentlemen, if there is no question, I think it's time to me to wrap up this the first day of the webinar. We have so many information and knowledge from the outstanding speakers today. We got information about malaria and non-human from Professor Tirapap, and from Professor Roger we understand about the animal and human interface, and from Professor Triwibawa we also know about Indonesian Global Health Consortium, and from Professor Isam in Morocco we got information about the programs of One Health in his university and in Africa countries, and from Professor Ira Nirmala, we understood about the sociology, health promotion, and One Health, and this connection. And from Dr. Ross, from France, we understand also the SAFE project, to prevent the next pandemics. And from Professor Padet, we know about the leishmaniasis in Thailand and its prevention. From Dr. Sioping, we got information about the health strategy in Xiamen University, including TB prevention. And from Professor Kumthorn Malatam, we got information about the antimicrobial resistance. And from Dr. Frederick, we understand about the interesting view from anthropological dimension on One Health. And the last is from Dr. Anne. We also got information about the Pressured initiative, which is a very important initiative to prevent the pandemics. I think that's all. What can we got to today? So many information and insight. I think we have to collaborate each other, as One Health is also a multidisciplinary and global approach and a collaborative initiative. So we have to hand in hand and work together, not only from health sector, but also from other sectors. I think that's all. What can I say? And thank you very much for all the speakers for your time and for your information and also support for the successful of this webinar. And I apologize if there is a mistakes while I'm being a moderator in this webinar. I think thank you very much again, and good afternoon.
Thank you. Good afternoon.
Thank you, Dr. Anne, Dr. Freddy.